important, as we all know. I mean, growing burden, cardiovascular disease, particularly for India, we're living longer, and also we have a lot of risk factors. So it's probably the number one problem that all of us are worried about. And and so it's also very important to talk about secondary prevention. We have two excellent speakers for this session, and I really want to thank them for agreeing to do this. We have Professor Srinath Reddy. I think he requires no introduction probably to this audience. He's held many hats, wore many hats. Most recently, he just stepped down from being the head of the Public Health Foundation of India, which is one of the top public health training and research bodies globally. And before that, of course, he was a professor of cardiology at the All India Institute of Medical Sciences, and he has many hats. So, Professor Reddy, and he writes prolifically, writes very beautifully and articulately for the lay media. And we were just discussing prior to this that a lot of times what we fail at is communication as scientists or as researchers or as medical personnel. We may know a lot of things, but we're not always communicating it to people in the right way so they can understand and take the right action. And we often see, on the other hand, a lot of mis and disinformation being spread uh, by social media influencers. So I think it's good to have people like Professor Reddy who also communicate really effectively to the lay media. So thank you, Professor Reddy, and over to you.
Good morning. Thank you very much for that very gracious introduction. I thought you nearly called me a Mad Hatter with so many hats going around. I must confess that I was quite bewildered by the initial communication which said secondary health, just as Professor Ashutosh Sharma was. But then I looked at the number of people who were being listed as planning the meeting, and somewhere I thought I saw Professor Richard Peter's name. Then I said, if Richard is there, then it has to be secondary prevention, and it has to be secondary prevention of cardiovascular disease. So at least I felt that would be the way to go. Because as a public health advocate, I too would have found it difficult to swallow that we prevent secondary health. So health is not to be prevented at all, either primary or secondary, but prevention is absolutely critical for health. That I fully agree. Now, in terms of secondary prevention, what happened? Slides are not moving. Keyboard से नहीं कर सकते इससे इधर अच्छा ठीक है right thank you ठीक है So firstly, I think it's important for us to state in the Indian context that there's been a marked health transition, as has been noted very clearly in many other low and middle income countries. We know that in terms of cardiovascular deaths as well as disability adjusted life years, there's been a marked shift in the contribution that's been coming from non-communicable diseases as a group, and particularly influenced by cardiovascular disease as the leading NCD. And this has happened between 1990 and 2016 as documented by the Global Burden of Disease Studies. We also know that when we look at the individual causes, then during this period, ischemic heart disease has really reached the top of the table from a 6th position earlier in 1990, and stroke, which did not even feature in the first 10, in 1990 has now come to the 5th position, and both of them are now increasing in terms of their magnitude and contribution to both deaths and disability. And we also know that low and middle income countries will follow the path of health transition, which will see an epidemiological transition where in the initial years, a couple of centuries ago, we had cardiovascular disease characterized by the dominance of rheumatic heart disease, nutritional cardiomyopathies like beriberi, but then it shifted over a period of time with increasing salt consumption in the diets to a rise in blood pressure, following the pathway of hemorrhagic stroke. But later on, as the social conditions changed and influenced dietary patterns and the living conditions of people, then we saw that atherothrombotic disease started appearing in much larger numbers with smoking, fat-rich diets, and others driving the atherosclerotic manifestation of thrombotic stroke and coronary heart disease. Therefore, we saw these appearing in a substantial way, but with far greater advances being made in the prevention of cardiovascular disease, both primary and secondary. Cancer is now becoming the dominant problem in most of the high-income countries, while in the low-income countries and the middle-income countries, while cancer is racing to the top, still cardiovascular disease remains at the number one contributor to death and disability. So when we look at whether it's actually affecting all the social classes, we also see a reversal in the social gradient as socioeconomic and health transitions advance within each country. The social gradient for non-communicable disease risk factors and for NCDs themselves, including the events, they progressively reverse till the poor become the most vulnerable. So we see a transition where the poor among countries and the poor within countries are going to be bearing the brunt of the NCD epidemic, and that we are already seeing even in cardiovascular disease. Therefore, the question then comes in is, what do we do about secondary prevention? While we must do everything possible to prevent the first event, there are going to be many people who have experienced the first event, and fortunately, because of the health system interventions, they have managed to survive the first event, but they still have to live with the risk of recurrence and possibly shortened lifespan. Therefore, the big challenge comes in as to what we can really do in order to try and ensure that they can continue to live a reasonably long, healthy lifespan without undue disability or other complications being imposed by the primary event. So here we have seen lifestyle changes being advocated, like tobacco cessation, dietary modification, physical activity, and stress reduction. Secondary prevention includes simple drugs and rehabilitation. And the drugs have become the major game changers in secondary prevention in terms of reducing recurrence and reducing the risk of fatal outcomes in people who have experienced either a heart attack or a stroke. Basic science and clinical trials have shown what works to save lives, to prevent recurrent events in atherothrombotic cardiovascular disease. Of course, hemorrhagic stroke requires a strong focus on blood pressure prevention in the first instance, and certainly continued management of blood pressure even as secondary prevention. But in atherothrombotic cardiovascular disease, whether it is ischemic heart disease or a thrombotic stroke or a transient ischemic attack, then one has to depend upon a combination of medicines which act through different pathways. We have antithrombotic medicines acting on the platelet pathway. We have medicines acting on the coagulation pathway, all of them trying to reduce the risk of thrombotic obstruction or clotting. Lipid lowering medicines in order to modify the raised lipid levels of particularly of LDL cholesterol, but also of other lipid components like, for example, triglycerides. And now lipoprotein little a is coming into the picture as an important contributor to risk, though drugs to reduce lipoprotein little a are still being tried out in trials, and we are seeing some preliminary results coming in from small RNA type of medicines, but we still have to wait for larger trials to be completed before they can enter the armamentarium. But as of now, we do have a fairly big range of lipid-lowering medicines. Then we have blood pressure lowering medicines, then medicines which reduce myocardial remodeling and protect vascular endothelium, like ACE inhibitors and angiotensin receptor blockers. Then we have medicines which reduce myocardial electrical instability and prevent serious cardiac arrhythmias, like, for example, beta blockers. And then we have anti-inflammatory drugs like colchicine now being advocated, but again, with some benefit being demonstrated in some trials, both for cardiovascular disease and cerebrovascular disease, but larger trials are still awaited, which are going to show consistency in terms of benefits of outcomes. So in secondary prevention, we are really focusing on medications like aspirin, statins, ACE inhibitors, and beta blockers. And lifestyle prevention, which goes under the name of cardiac rehabilitation, but essentially consists of not only remodeled physical activity, but also smoking cessation and healthy diets. When we look at the summary of secondary prevention guidelines and classify them as per the current canons of evidence assessment, then we find that antiplatelet agents really are class 1. And also we find long-term dual pathway also coming into the picture. And statins, class 1 again, beta blockers come in again as class 1, and ACE inhibitors, class 1, or angiotensin receptor blockers, class 2A. It does not matter what the class actually being listed is, all of them have been proven to be life-saving and reducing the risk of serious disability, and therefore they're very much in vogue in terms of actual clinical practice guidelines. Other drugs which are used but not necessarily part of the standard treatment always are nitrates, calcium channel blockers, metabolic modulators, and other vasodilators. They really do not feature in that list of highly effective drugs to be utilized as class 1 drugs. So the question comes in is, if there are different categories of drugs which have all been shown to be pretty useful in protecting against recurrent events and seriously reducing disability, then should they all be used in combination to get the maximum benefit possible? But the challenge, of course, is that even if they are prescribed, they may not necessarily be used adequately by clinicians who may not prescribe all of them, and certainly the patients may not be necessarily adherent to a combination of multiple pills being served separately. And therefore the question came up was, is a single combination pill possible? While Walden Law have been credited with the polypill, frankly, I must share with this audience that the idea actually first came from Professor Richard Peto. Somewhere in Welton Park or in, somewhere else, I remember, when he, Salim Yusuf, and I were sitting, literally on the back of an envelope, he sketched out what the potential benefits of a single pill would be and how many lives would be saved. And that became a fairly popular idea. And then Walden Law, of course, went and came up with their own formulation and patented it. And Richard Smith from British Medical Journal called it the most important BMJ article published in 50 years. And of course, the polypill is such an attractive proposition because it provides for comprehensive risk factor control of the biological risk factors, because by looking at lipids, blood pressure, thrombogenesis, all of them, and of course glucose control when added. Several factors are addressed simultaneously to reduce the composite risk, regardless of the initial level of the risk and without screening for them. Now, Professor Peter felt that the health system, particularly run by physicians, is an obstructor of good scientific medicine being widely practiced for saving lives. He said it is they who stand in the path of progress, and they are preventing this kind of interventions to be used adequately. And since they start exercising their own judgment, we must try and push the physicians out of the way and get the polypill prescribed for everybody. In fact, if Richard Peter had his way, he would put it in the drinking water supply, at least the statins. But nevertheless, the idea is that you need not necessarily go around having measures of what the initial LDL cholesterol level is or what the initial blood pressure level is, but you can actually give a single pill which acts across the continuum of risk, because we know that all risk factors act across a risk continuum. They don't act only across threshold levels. So he said you can go ahead and use it that way, and regardless of level and without screening for them. And you can have a population-wide impact. And of course, Walden law said you should, everybody above 55 years, you should get it. That, of course, has been challenged elsewhere. But high efficacy, primary prevention prevents half of cardiovascular disease safely and at low cost. But the second, the polypill prevents half of cardiovascular disease safely and at low cost. The idea is that you can actually achieve high efficacy. And there's really no screening or monitoring required. These were the things that were advanced. But practicing physicians cavilled and said, we need to measure the risk factors. We need to titrate the medicines. We just can't go around with one blunderbuss of a pill. And therefore, the uptake in most countries, especially in India, was very poor. Even though Salim Yusuf came up with his own formulation of the polycap or the polypill for India, the uptake has been extraordinarily poor, because physicians still wish to exercise their judgment, individualize the patient treatment, use a combination of drugs separately prescribed but not prescribed in unison, and titrate the doses as they go along. So why is polypill an attractive option? Certainly it is there, but there's also strong evidence. Multiple studies have been done in different parts of the world to show how effective it is in secondary prevention, and some have tried it even for primary prevention. Now, I am only quoting some of these results. The Umpire trial results, Valentin Fuster led this trial, in which they used 3 drugs, not 4 drugs. But here you had a very high level of adherence. There was a substantial reduction of systolic blood pressure, meaningful in terms of cardiovascular risk. And there was also a substantial reduction of LDL cholesterol, again meaningful in terms of risk reduction over a large patient population. And if you look at the fixed dose combination effect in the CURE trial, again you find in terms of composite cardiovascular death, non-fatal MI, and non-fatal ischemic stroke, and urgent coronary revascularization, you find a substantial benefit in the polypill and the Kaplan-Meier curves. Now, if you look at the summary of secondary prevention guidelines and class of recommendation, this we have already seen in terms of drugs. But what about non-pharmacological interventions? Their physical activity has been classified as class 1, healthy diet as class 1 to 2, and that of course generally prescribes no trans fats, reduce saturated fats, increase monounsaturated fatty acids, polyunsaturated fatty acids, more fruits and vegetables. Smoking and tobacco cessation in all forms of tobacco, alcohol moderation, weight management, cardiac rehabilitation. All of these are combined as non-drug interventions. Just to quote a couple of the dietary trials, you had the Predimed trial and the Mediterranean diet, again recommending olive oil, tree nuts or peanuts, fresh fruit, fatty fish, legumes, white meat, wine, and discouraging the carbonated soda drinks, commercial bakery goods, and full of trans fats, and now ultra-processed foods. All of these are being discouraged. And then you go to a more recent recommendation from the Lancet Eat Commission, and again, very similar, diversity of plant-based foods with a lot of phytonutrients and fiber, low animal source foods, balanced intake of unsaturated and saturated fats, reduced amounts of refined grains, and highly processed foods and added sugars. With ultra-processed foods now becoming far more important in terms of dietary interventions being recommended by many global agencies, India too is now looking at it as to how to actually ensure the reduction of ultra-processed foods through regulation and health warnings. The other measures in terms of smoking or tobacco cessation, alcohol has been already listed as moderation, if not full abstinence, weight management, and cardiac rehabilitation. Now, myocardial revascularization as secondary prevention can be talked about, but I will not do it because angioplasty or stenting and CABG for surgery have their own specific indications and not used generally in the sense of secondary prevention. In terms of how these are actually going to be administered, however, all this knowledge does not translate into effective uptake or action through the health systems. And that's where the lament of public health lies. In terms of the gaps in the management of non-communicable diseases overall, presently the rates of awareness, treatment, and effective control are low in low and middle income countries. Health systems are not geared for chronic care. Costs of treatment are high for procedures as well as for drugs. Health workforce is not adequately skilled for NCD, that's non-communicable diseases, and mental health care. Unregulated private sector often provides inappropriate care. And we see that health systems do matter because when we look at the contribution of non-utilization of care to poor quality care in this particular slide published in the Lancet, we find that in cardiovascular diseases, there's a substantial amount of non-utilization of care despite adequate evidence of proven benefit. And coming to the Indian experience, again, you can see from this publication by Dr. Gupta and others from Rajasthan that cardioprotective secondary prevention medicines, aspirin, beta blockers, and statins, and ACE inhibitors are being used in much lower quantities than actually needed by the population. So, but despite the fact that they have actually demonstrated benefit, there is very little uptake that's happening. And this is very clearly shown here that if you actually use all of these drugs in combination, then there is a definite combined benefit, cumulative benefit on mortality, but on fatal and non-fatal outcomes. But here in this particular slide on cardiovascular mortality. But nevertheless, the uptake is pretty low. Secondary prevention, if we want to move from efficacy to effectiveness, we need to improve practice patterns of healthcare providers. We need to integrate effective secondary prevention into primary healthcare. And we need to enable uptake and adherence by patients by improving availability, affordability, knowledge, motivation, support systems, simplified regimens. And we need to strengthen health systems for chronic care, build efficient referral and follow-up systems, vascular and metabolic clinics being operated, if not right at the front line of the primary health care, at least at the next higher level, and which we are doing now in community health centers and district hospitals. Involvement of non-physician healthcare providers, this is absolutely pivotal. Monitoring and evaluation on a regular basis. The barriers for adherence and secondary prevention are at the community level, low perceived needs, lack of heart-friendly infrastructure, government policies for food and tobacco are not as strict as they ought to be, media apathy, health systems barriers are resource constraints, poor access and availability, lack of advocacy. Barriers to adherence and secondary prevention, which are patient-related, are older age, where there is lesser degree of health awareness, particularly in terms of the nature of pharmacological treatment, female gender, low socioeconomic status, social isolation, comorbidities, multiple stakeholders, disparate messages coming in from different parts of the health system and healthcare providers, finance and insurance. When insurance doesn't cover, then out-of-pocket expenditure can be high, particularly for chronic conditions which require lifelong care, and geographic factors. Barriers that exist at the provider level are lack of understanding of patient needs, prescribing complex regimens, failure to explain benefits and side effects, lack of focus on lifestyle changes, lack of continuity of care, low clinical referrals, clinician perceptions, and overtreatment. Intervention to promote adherence at the provider level, therefore, will have to have improvement of provider education, teaching adherence promotion techniques, motivation, cost awareness, and single pill combination or polypills when they become widely available. Requirements for the ideal journey according to the World Heart Federation. When I was president of the World Heart Federation, we initiated some roadmaps, which Professor Salim Yusuf continued. And one of the 3 roadmaps that came during my initial tenure was on secondary prevention, apart from tobacco and hypertension control. So the requisites for an ideal journey are: healthcare systems should be accessible not only during the acute phase, but also during the longitudinal follow-up to ensure lifelong care. Practical clinical guidelines recommending priority intervention should be easily available. Healthcare professionals who can prescribe recommendations should be available. Priority cardiovascular secondary intervention should be available and affordable to patients. Patients should be given help to better adhere to recommendations, and an information system should be in place to monitor the progress in CVD prevention, not only primary but also secondary. Interventions to promote adherence at the health system level would be to prioritize secondary prevention, education of providers and patients, simplify referral and enrollment processes, increase resource for secondary prevention services, increase capacity and capabilities of healthcare providers, and increase capacity of the programs themselves. Now, some of this is happening with the help of new technologies. mHealth and task sharing, of moving some of the responsibilities previously assigned to physicians to nurses, nurse practitioners, or even technology-enabled other frontline health workers, the non-physician healthcare providers, is proving effective. This is a study done by some of my colleagues, mHealth and task sharing, the Empower platform, and that has shown benefits as well in terms of improving the uptake of evidence-based treatments. Development of smartphone-enabled hypertension and diabetes mellitus management package to facilitate evidence-based care delivery in primary healthcare facilities in India. The Empower Heart project again showed a fair amount of benefit, which can be utilized also for secondary prevention. Cardiac rehabilitation has been the traditional mainstay of post-event protection. It has been widely endorsed by several professional associations. 11% reduction in long-term all-cause mortality has been claimed in publications, and 39% reduction in all-cause hospitalizations has been also reported. Improvement in quality of life has also been reported, but the limitations are need for a multidisciplinary team being present everywhere, poor uptake even in high-income countries, and scarce and expensive in India. So, when I was given the topic of cardiovascular health and secondary health, I did a Google search as I had to understand what the topic was. And then I discovered that there is actually a recommendation that's been made by Redfern et al. In the Journal of Cardiovascular Health in 2024, saying that cardiac rehabilitation is a time-limited intervention which is not likely to provide long-term protection. We ought to move to secondary cardiovascular health. So the term actually exists in literature. I was interested in discovering that. So the key messages are need to move from a short phase of post-event rehabilitation to a continuing phase of patient-partnered positive program of cardiovascular health from health protection and promotion. They emphasize a number of P's: personalization, processes, patient-centered care, parlance, and partnerships. I will not elaborate on that. But they do aver that this will improve engagement with secondary prevention at the systems and population level if we move away from rehabilitation as a facility-based, short-term, structured intervention into something that is much more built into the daily living. So here comes India with its potential to contribute to this concept with yoga. Whereas cardiac rehabilitation is a program of education and exercise sessions that help MI patients to get back to everyday life as quickly as possible, is found to be highly effective. It requires large multidisciplinary team, generally unavailable in both private sector and state-funded hospitals in India, which have limited resources. But yoga incorporates physical practices, pranayama, meditation, and relaxation techniques, and is practiced as a way of life, including dietary changes. It improves physical fitness, reduces stress, and advocates dietary and lifestyle changes, and may even improve motivation for adherence to drugs. Requires considerably fewer resources, example, a yoga teacher, and often the follow-up need not have the continued presence of the yoga teacher. And therefore, my colleagues in the All India Institute of Medical Sciences are actually conducting a major study called Yoga Care Trial. This is as a rehabilitation after acute myocardial infarction. The preliminary results were presented in the meeting of the American College of Cardiology and have been also published partly. The trial is still progressing with funding from the Indian Council of Medical Research. The protocol was developed through a rigorous process. It involves multiple centers across the country, and it incorporates modern as well as ancient precepts. So, in the trial, which is still ongoing, the results presented at the American College of Cardiology showed that there was an improvement in the primary outcome in the intervention and the usual care group, and there was also a manifest effect on some of the key risk factors: blood pressure, fasting blood sugar, LDL-C, and abstinence from tobacco use. While the intention to treat analysis was underpowered, at least per protocol adherence in terms of actually people who followed the advice and practiced most of the measures, there was a dose-response relationship of benefit. So a larger trial is still in progress. So thank you very much. I believe that when we talk about cardiovascular health and we talk about secondary prevention, but secondary prevention moving to secondary prevention being built into a larger healthy lifestyle, which includes not only drugs, but also many other modifying measures of our living habits, perhaps we can actually have a multinational study with the British and Indian hospitals participating in something like the Yoga Care trial and see how best we can address some of the challenges of secondary cardiovascular health promotion and event prevention. Thank you very much.
Thank you very much, Professor Reddy. If it's fine, we'll have the discussion after both the speakers. So I'd now like to invite Professor Riaz Patel from the University College London to make his presentation. And please hold on to your questions and comments so we can have a good discussion after Professor Patel's talk. Yeah, thank you.
So while the team are getting the talk up, just to say thank you, first of all, to the Royal Society and the Indian side for inviting me. I was admitting to Crystal, I felt a little bit like a fish out of water here because cardiologists and the Royal Society generally don't sort of overlap too much. I think there's maybe 3 or 4 cardiologists ever in the Royal Society, of which Thomas Lewis was one, and he's a fellow UCL person, so I guess there's some sort of a link here. I guess the other thing is also a moment of pride, I guess, for myself and my family as an Indian who migrated to the UK and now have the opportunity to speak to colleagues across the country. Good. Are we ready to go? Great. Thank you very much. All right. So I kind of took some editorial liberty and assumed that this is the title that was actually being asked for. So I've done that. So hopefully we're all on the same page. Before I start, I guess it was worth pointing out that in public health and cardiology, we have a subtle difference in terms of how we define this. So primary prevention, I think generally in public health means sort of smoking cessation, things to avoid disease. And secondary prevention is management of things like risk factors, blood pressure, and so on. In cardiology, we go one step further, and generally secondary prevention is stopping the subsequent heart attack after the first heart attack. Primary prevention in cardiology is generally management of blood pressure, and we even refer to primordial prevention as what primary prevention is. Anyhow, I think we're all on the same page talking about stopping subsequent events here. So I'm going to give a very UK perspective, conscious obviously we've heard from Prof. Reddy about the Indian side. And really, it's probably a story of a clinical academic in terms of my kind of understanding experience of secondary prevention and the journey it's led to me. And hopefully, you kind of see this nice kind of circling of the discussion as I go through this. So I work across UCL and the Barts Heart Centre, which is the largest heart centre in the UK. And effectively a preventative cardiologist as well as a clinical academic. So again, looking at from a sort of Western perspective and high-income countries, we've seen some good successes in terms of CVD mortality over the years. You've seen these sorts of figures in UK, US, and other countries of really quite improvements in mortality. We've kind of attributed a lot of this down to control of risk factors across public health, but also lots of developments in advancing treatment, primary angioplasty, thrombolysis, and so on and so forth. I say this is a success, of course, because when you look at the similar sort of data in India, again, blue and red in Western nations, and you can see sort of in India, actually that hasn't happened yet. But in many ways, as we alluded to earlier, what's happening in the West might be a potential future of what could happen in India as well. So the challenge we have is that although we're stopping people from dying from their first event, they are living on. And they live on with chronic disease. And people who have chronic disease are not out of the woods. So in the UK, we've got an estimate around 2 to 3 million. I tried to find an estimate for India. It was very difficult. If someone can give me a number, that would be really helpful for future. But I'm sure it's substantial. And when people do have coronary heart disease, they remain at high risk. So we know that even within 5 years, there is still a substantial 20 to 30% mortality from cardiovascular disease. And this is despite contemporary treatment. So this is data we have from primary care records in the UK, showing the different types of cardiovascular disease and mortality events. But also you lose years, you lose sort of quality of life, and we know from data from the sort of global burden of diseases studies that you do lose lots of years for disability. And of course, treatments are expensive. So we're finding out now that we are really buckling under the cost of treatments. If you have a heart attack and then you have heart failure, then you might need a special pacemaker, which is called an implantable cardiovascular defibrillator, which can cost thousands of pounds to implement, and then recurrent admissions and so on. You can start to see how costs can rapidly accumulate beyond initial estimates. And in the UK, again, these are sort of estimates that we have. So there's a real focus now to kind of tackle this. So how do we improve secondary prevention? How do you stop this problem or improve this problem of people who live with heart disease? First is we can find more risk factors. Really, you know, we heard from Prof. Reddy about the common things that we currently do, blood pressure, lipids, and so on. But surely there must be more. And if we can find those more, we can hopefully treat them even better. Maybe there are completely new mechanisms, things that we haven't thought about. We've touched on thrombotic lipids and inflammation, but maybe there's completely undeveloped pathway that we need to discover that might be unique. We need to improve risk stratification. Who's safe to allow kind of discharge back to a GP? Who actually needs more intensive follow-up and treatment? And of course, better use of available evidence therapies, which we're notoriously poor at doing, and as we've heard already, is quite a challenge. So I'm just going to kind of take you through a little whistle-stop tour of all of that. I'm not going to spend too long on the epidemiology, but for the epidemiologists, maybe this will spike your interest a little bit. So when you look at recurrence of disease or secondary prevention, you try and find risk factors, you often find that there's various odd things that will happen. So for example, on the left side here, you've got a South Asian ethnicity challenge. So one of my colleagues did a study quite a few years ago, looked at South Asians as a risk factor for cardiovascular disease, and we know we are at higher risk. However, when you look at subsequent event risk, that seems to be significantly diminished and maybe even protective, which is a very weird kind of observation. Similarly, we've got BMI paradoxes that everyone is probably familiar with, and even things like HDL, which are very pronounced, ERC data, of course, showing. But when you look at patients with cardiovascular disease, that attenuation is significant. And sometimes that manifests into trials that fail if you prioritize a treatment based on what you saw in first event risk factors compared to second events. So the point was that it's a bit tricky, the risk factor assessment. So what we did is, well, we've got access to a large sort of primary care national database in the UK of millions of people. And we said, why don't we look at all the risk factors that we know contribute to a first event and then see what they do for a second event? And is this unique to some factors, like some people would have you believe? You know, it might just be a BMI paradox, has lots of biology behind it. Or is this actually something beyond that, which is more systematic? So we looked at this, 3 million people without CVD, 57 with CVD, sorry. And you can see with multiple risk factors, you can see all the sort of usual suspects on the first event panel, which is on this side. But when you look at second events, you can see this huge attenuation of pretty much everything. And the point here is really to make that this is also affects the shape of associations and so on. So what we wanted to really demonstrate here is that it's not that things are less important. It's just there is likely to be a systemic bias here, a collider stratification bias, methodological issue, which is causing all of these symptoms. So when you hear of people saying, oh, LDL is not important in secondary prevention because the association is minimal, and you get a lot of cholesterol skeptics who try and do this, it's nothing to do with that. It's just a pure statistical challenge here. And you can see that with risk prediction, I can see Emanuele's joined us in the room. First event risk prediction models, fantastic. When you try and do the same risk models in secondary prevention, they don't really work so well. And that could be a reflection, again, of the biases we talked about. So anyway, so that's just a little bit of epi just to keep some interest in the room. So then we talk a little bit about precision medicine, as you will have all heard. And we enter the genomic era when the hope was that through understanding of genetics, we'll be able to really kind of pin down some of these questions around recurrence and who might be susceptible to further cardiovascular disease. Genome-wide association, as I'm sure you're all familiar, you take a bunch of people with and without disease, you look at sort of SNP arrays, measurements of the variation in the genome, and then you see which ones crop up more in one group than the other. And this was all kind of kicked off in sort of the early sort of mid-2000s, so 2007 or so. I was fortunate enough to be part of this early discovery of 9p21, which was one of the first signals that was identified as associating with coronary disease risk. So as you know, prior to that, genetics has really struggled to find good genetic risk factors for cardiovascular disease, but 9021 was one of those. We're still not sure exactly how it works, but nonetheless, it was discovered now nearly 20 years ago. So it's been quite a journey with this. Since then, however, we've expanded our biobanks. We've got huge international sort of collaborations, Cardiogram 4C and others, which are sort of very cardiovascular genetic consortia. And we've discovered multiple different genetic variants in multiple different pathways. Many of these are kind of being investigated actively in functional studies by research labs across the world to try and see, can we find that elusive new treatment pathway that might be more important for cardiovascular disease than what we already have. So the question then is, well, could you do the same for secondary prevention? Could you also find similar genetic hits that might be more unique to factors that biologically might mean someone is more predisposed to having a recurrent event than a first event? So to answer this challenge, we set up this sort of international consortium. We managed to pull together around 250,000 people across about 65 studies around the world. So these are studies where people have found people with heart disease and followed them up for events and preferably biobank them as well. So we searched PubMed, all of our contacts, pulled everyone together, as many as we could find, and we managed to create this consortium. We used a federated analysis approach, which kind of bypasses the sort of challenges of trying to get data across boundaries, country boundaries, and managed to kind of do this using this sort of approach. And it worked. And we were able to demonstrate a positive control with smoking, for example, demonstrating significant association as you'd expect. But with genetics, we've kind of found that same attenuation as we saw earlier. But the association that we saw prominently in the first event setting, which was a cardiogram C4D, was significantly attenuated once you look in people who have coronary heart disease. So it's starting to become a bit of a challenge to understand from observational data what you might be able to do in secondary prevention. I sort of flagged that as one of my achievements was to try and get the authors in a consortium to do that many disclosure forms in one day. So if anyone's got more, please let me know, but I'm quite proud of that achievement. So then we thought, well, can you do a discovery analysis in subsequent stages? So can you do a GWAS, like I said, that we did in people with and without cardiovascular disease, in people with cardiovascular disease, but people who've had a recurrent event versus those who've not had a recurrent event, to see if you can find any differences between the two. So again, we managed to pull together enough cohorts from around the world in order to do this, run our various analyses, looked up the ones that have been associated with the first event already. We found a few that was significant. But importantly, we found new hits, which could signal new mechanistic pathways for recurrent event risks, so plaque vulnerability, plaque rupture, which is something that in cardiology we're quite keen to try and better understand. So this is all kind of currently work in progress that we are moving forwards. So that just gives you a little bit of flavor. So a bit of epi, a bit of genetic epi so far. Then the question of risk stratification comes in. So if you've we talked about earlier, but we don't really have good tools to try and stratify people who might be at risk of subsequent events. So one of the big questions is, well, can you use genetics to do that? And can you combine all the genetic hits that we found into one score? Because there will be individuals who have lots of those genetic hits who are at the end of the spectrum. And this is the concept of a polygenic risk score, which is essentially the sum of the genetic risk across the genome into one score, one composite score. Sounds an attractive idea. You can do it for multiple diseases. Of course, I'm just talking cardiovascular. You can do it for breast cancer. You can do it for whatever you want. And that's been done in cardiovascular disease. So this is a paper by Michael Inouye, one of my colleagues, and demonstrated that individual risk factors, when you add the genetic risk on top of it, you get even better kind of risk prediction. And so this is quite potentially a promising approach. Similar work done by Amit Khera and Sekar Kafaresan in the US, again, demonstrating similar value for a polygenic risk score. So all that sounds really exciting. Can we do it for subsequent events? Can we use that same risk score in people with cardiovascular disease? And we did this in the UK Biobank, and actually we found the same phenomenon that we've found already, which is everything seems to be attenuated once you start looking in people with coronary disease. So this is a real methodological challenge for us, but I'll come back to that in a second. The other use of a polygenic risk score is in pharmacogenomics, which is, I'm going to go back, there you go, which is to see whether polygenic risk scores can stratify people who might benefit from more treatment or certain treatments. So there's data that's been done retrospectively on statin trials which demonstrate that if you have a high polygenic risk score for coronary disease, you might get a greater absolute risk reduction with statins. Various questions around that, but that's potentially one of the arguments. And it does sort of bring that CTT figure back to mind, which I'm sure everyone's familiar with, that statins reduce sort of pretty consistently around a 20-25% relative risk reduction in cardiovascular disease, no matter where you start from. So now there's this question of, can polygenic risk scores identify people with higher value from certain medications? We can also do that with more expensive treatments like PCSK9 inhibitors, which do require a bit of stratification on who we give those to, who we don't. Again, perhaps not immediately relevant in sort of emerging economies, but certainly it highlights the concept of the use of polygenic risk stratification for genomics, for treatments, I should say, in secondary prevention. Challenges with polygenic risk scores. I have to mention this. Again, Emmanuel is in the room. He knows kind of about my feelings about polygenic risk scores. I think there are lots of challenges around polygenic risk. I mean, first of all, what is a polygenic risk score? Which one do you use? Can you apply it in one setting compared to another? Ancestry, we're in the right space to talk about this. A lot of this is all European descent data. When you start trying to use polygenic risk score prediction across different ethnicities, you see this huge variation. We need data from local populations to be able to understand them. And I think there's a big push now to try and get that happening. But until we do, that's going to be a major challenge. There's a whole IT logistics of how on earth do you even use a polygenic risk score in your clinical data systems? How do you apply it in your day-to-day clinical practice? Ethics, education, not just for patients, but for us all. If you're going to start applying clinicians to use genomics, you really need to step up the education for that. So these are just some of the challenges. Perhaps my favorite paper of the year has to be this one from colleagues earlier in the year in JAMA, where they took just a few individuals, 5 individuals here, and ran different polygenic risk scores that have been published over time and by different commercial providers, and demonstrate this huge variability in what your predictive performance is based on the polygenic risk score, just demonstrating that actually, what does it mean? Which one do we pick? So there's a lot of methodological challenges still before polygenic risk scores are ready for kind of prime time use. Selection bias, again, just to highlight. So I think the challenge I mentioned earlier about finding risk factors from observational data is really likely attributable to collider bias and selection bias here. And we've done various methodological work with colleagues in the UK to try and understand this better. And I think now there's a whole field of work that's grown around disease progression. So we're not just talking cardiovascular disease. This applies to any disease where you're kind of conditioning on having the problem first and then looking for associations afterwards. So what are the next steps? Well, at that time I was kind of working on all of this. It's like, well, we just need more data. We need more omics. We need more metabolomics. We need more. And then now with kind of AI and everything, we're going to be able to get to that point where we can really risk stratify people. But then, of course, the reality is, this is going to be cost. There's governance issues. And then the big question is what's the impact? How much are we going to be able to impact on actual care, on the things that we really care about? So that for me was quite a pivotal moment. And at about the same time as we opened sort of the Heart Center, the reality is we live in this sort of space up there with these higher institutions. But the reality, even in parts of London, is deprivation, and it's a big challenge about what's going on. In the UK, we've got data now showing the association of deprivation with cardiovascular risk and mortality, and the sort of circle in the top is kind of where a lot of the boroughs that we work in are. So we are working in high deprivation, high CVD risk areas, and potential sort of synergies for colleagues in the room. And in the UK, there's now this big push. There's always been a push, but now I think everyone is really realizing prevention has to be a priority. And more importantly, I was really interested in Prof. Reddy's talk earlier about poverty, because we're now seeing that all those improvements in CVD, we're now starting to see an uptick again in the UK. So that progress success slide I showed at the beginning, it might be reversing. And that could be partly because of increasing health inequality. So we've got more and more deprivation now. We were talking with colleagues around the numbers of sort of homeless people and things that we're seeing. So I think there is a question here about what is happening at a societal level in the UK. So what can we do now? So as a clinical academic, I see patients on a day-to-day basis, as well as being in the university. I work in the hospital. And I see the harsh reality of people who are not taking their medications, who come in, who are smoking despite having had a heart attack, and all these realities. It's all very well for us to say from our sort of university lecterns that we should do X, Y, and Z, but the reality on the ground, as many colleagues will know in the room, is very different. So what can we do? Well, I say, well, let's look at LDL. We know from genetic data, from all sorts of data. I'm not going to go into this, but if anyone wants to, we can discuss later about Mendelian randomization and how LDL is so important in controlling both for primary prevention and secondary prevention. And let me just go back a slide. So that sort of question that came, I think we touched on it earlier about Sir Richard Peter and others, is well, you know, we as clinicians, we're kind of always focusing down here. But actually, if we took a step back, we can probably do a lot more good at a population level to try and lower LDL for more people than fewer. In the UK, polypill hasn't taken off, as we've heard. But the next best thing we can do is guidelines in terms of impacting cholesterol management and LDL. Oops, sorry. So one of the things we've worked recently with NICE, which is our, as you've heard, which is our kind of health economics and sort of technology appraisal body. We used the same real-world data that we used in the earlier work I showed you. Worked with the health economists there. We did some Markov modeling, and essentially came out with a recommendation in the UK to have everybody in the UK who had a heart attack or a stroke to get their LDL below 2. Now, you might say, well, guidelines have been saying that for a while, but not at a national level where it's sort of almost policy. All right, because health cost effectiveness always comes in. So a lot of the European guidelines, the American guidelines all say aspire to 1.8 and to 1.4 and so on. But very few have actually said this at a national level. So we've set probably one of the first levels at this, and I'm proud that I was kind of part of it. That's kind of my sort of argument to say we can actually make impact from academia. And, you know, estimated events just by getting more people under a more generous level. So 2 as an LDL level, for those who are not familiar with cardiovascular disease, is relatively generous. It's not the strictest. Now the European guidelines say if you've had a heart attack, you get your LDL down to 1 or 1.4. But actually that argument, or even if we just improve a little bit, we can make a big difference, is quite relevant. So we didn't stop there. So then the next question is, what about implementation? Again, as I said to you, I kind of work at UCL, but I also see patients locally at Barts, and we cover a whole 3 million population as just in part of London, which I know is peanuts compared to India. But for us, you know, the concept is that we are responsible for a large burden of the local population. And the question is, can we leverage some of the academic expertise and the clinical expertise to impact population health? And I don't know how it is in India, but particularly in the UK, there's very, you know, we're all kind of in our compartments. You have universities, you have hospitals, and then you have public health, and there's very little kind of intersection between the three. So we've developed a whole program of work that focuses on secondary care, upskilling primary care, working with the community around improving cardiovascular prevention generally. Again, I could talk a lot about that. That's a whole talk in itself. But I wanted to just focus on the secondary prevention work where we've just kind of said, okay, well, how can we get our local population? You know, let's forget about the world for a second. Let's just go very local. And say, how do we get them better? How do we get our patients with CVD taking their statins? And we worked with primary care. We've upskilled primary care teams, their staff, their nurses, etc. We've demonstrated that even with just leadership from secondary care and universities, you can do a lot. So these are just figures demonstrating some impact of reducing that kind of underuse of statins in people with cardiovascular disease. We did a very data-driven approach. We went to the areas of highest deprivation, highest need. And I was very proud to say that actually we took Northeast London, which is our region, from being kind of one of the lower performers in England to being the top this year in cardiovascular disease. Just demonstrating that it might be small, relatively speaking, but sometimes you need to go from the global setting, you know, as I've done with the Genius CHD Consortium, to actually go right down and say, what can you do near term as well? And then just finally on health literacy, I think we've touched on this before, and I think this is such a big problem. In the UK, I think there are estimates that about 2/3 of the population do not really fully grasp health information if it's just expressed in words and numbers. And when we're talking about risk, we are absolutely talking numbers. And you can see how many people actually understand this stuff. And, you know, again, one of the small projects we've done, the health literacy average of our local population is probably the equivalent for an 8-year-old. That's what. So when you're talking about secondary prevention, trying to tell people to take statins and blood pressure, you know, you're fighting a losing battle if people do not understand what that's all about and try and convey that. So anyway, that's a kind of a general message. So in terms of our approach, we're kind of very good at doing all of the stuff on the left. We'd love to collaborate with colleagues in India to develop more of that work. I'd also want to work with very local communities. So again, there are lessons that are learned that can be bi-directional here. I think in the UK, we are also now struggling. You might have heard from money, as taxes are probably going to go up this week, I suspect. So, we want to also learn from India of, what you've done. Maybe there are other approaches that we can kind of apply to our local populations. So I think there's a sort of nice reflection here. UCL with Center of CBD Prevention, again, looking for collaborations internationally. So I'll wrap up there. Just to sort of summarize, secondary prevention is a global problem. It's a growing problem. So, and countries like India and others will start to feel this, I think, in years to come. As more and more people survive, there will be a big burden of secondary prevention. We've done some work which has given some insights into risk factors, and maybe that will go on. There are issues around methodological issues that need to be addressed. But I think the big question is that, it's kind of almost like I said, my journey as to going from really deep to now stepping back and saying, actually, what can we do broader? And can we develop new ways of integrating the work that we do to make impact? So I'll stop there, and yeah, happy for discussion and questions.
Thank you very much, Professor Patel. So now we have about 10 or 15 minutes for discussion, Q&A, comments, or try to be as provocative as possible. I think we've had two very complimentary talks, and clearly we need more research. I think that's very evident from both the talks. There are lots of things on the table, and how do we do this at the population level? What sort of benefits can we expect to see? I think these really require the Richard Pito kind of very large trials that would help answer some of these questions. Because it's important to demonstrate, like I said, effectiveness, but also cost effectiveness in a particular setting. Otherwise, the government is not going to be convinced to invest in something unless we can demonstrate that it is, for this particular population, a cost-effective intervention. And it's easier to convince them to invest in treatments, in tertiary care, and more hospitals and more centers for surgery and cardiac care than in prevention. So that's why it takes more research and more evidence to do that. But let's open it up now for both the speakers. Yeah.
Thanks very much. I wonder if you could give us a flavor of what primary data you guys have available in your various healthcare systems and how comparable they might be, especially in the UK, obviously, has maybe a bit more comprehensive, but also is subject to a lot of trends over time. So just, I would just get an interest in where do you have, for example, in India, very good primary descriptive epidemiological surveys of the burden of cardiovascular disease, so you even understand how stable that is. And also in the UK, for example, when you're looking at the risk factors for secondary prevention, the background in what we prescribe and how we've prescribed over time has drifted quite a lot too. So how do you account for those temporal and cross-sectional effects?
Not to worry. As far as India is concerned, much of the data has come from surveys conducted by researchers from different institutions, but not necessarily in a nationally representative sample. But since we are now talking about not just hospital-based data, a lot of registries have been set up in hospitals, and they're actually yielding a fair amount of data. And some of the issues related to adherence and how to improve adherence, all of that is coming from this kind of registries that are being run. Some from Bangalore, some from my colleagues in All India Institute of Medical Sciences and former colleagues in All India Institute of Medical Sciences. But also the OSS registry that Salim Yusuf set up and others, the CREATE registry and so on. But if we're really talking about what's happening across India, particularly given the fact that now cardiovascular disease is becoming a major problem in the rural areas and smaller towns, it's no longer confined to the big metros. We do not have nationally representative data. However, now there is a concerted effort by the government of India in the primary healthcare system to ensure that cardiovascular disease prevention, both primary and secondary, are advanced. And with increasing strength of India's digital health system, there can be nationwide documentation now. And therefore, in a couple of years, I think we'll have much greater data, which will be representative of the country. And it'll have data which can be disaggregated to urban and rural areas and to richer and poorer states, gender disaggregated. All of that should be possible in the next coming few years. But as of now, the answer is we do not have nationally representative data. Second, of course, is the question you asked about changing trends, temporal trends. Yes, there's the marked changes that are happening. And as I said, the reversal of the social gradient has been documented fairly clearly in India, that just as in the West, it starts with the higher social classes, the more educated, then it moves fairly rapidly in Indian circumstances to the poor as the mediators of risk become mass produced for mass distribution, whether it's tobacco or ultra processed foods. And the rich gain education and they have greater affordability of healthier foods, then you see the social gradient reversing. It has taken much shorter period in India for that reversal than in the West. But the fact is, given the fact that it's a mass epidemic now, the government of India is actually trying to take measures to try and introduce preventive measures, both primary and secondary, into the primary healthcare system. And we hope that will yield benefits. But one other thing that I must say, there are Indian specificities. India, the typical metabolic syndrome is much more prevalent in India. Therefore, it's not just the LDL which is predicting the risk, but the TG-HDL ratio, which is a better marker, surrogate marker of small dense LDL, that is much more operating in the Indian circumstances. So even in terms of pathophysiology, we find differences which probably need to be accommodated. So if we are really going to go for screening tests in the Indian primary healthcare system, we may not suffice just with an LDL, but we go for a TG-HDL ratio.
Yeah, I mean, I'd agree with a lot of what's been said there. I think you raised about the question about drugs and use, and we've got, as you know, fantastic data that we can tap into in the UK. But I think the message coming from all of that data is still very much the same: is that people don't take their medications, and even in after a heart attack, when people are most motivated, they will start on all the 5-6 drugs that we want them to take. But after a year, depending on which sort of setting you look at, maybe about half of people might have stopped their statins or more, and then that drift continues offwards. So it's almost like we can do all of the tests, everything in the world, but if we don't get people to take the medications, where do you go next? And I think that is one of the big challenges. I think that might be a topic for discussion later on. So I'd agree, if there are ways we can crack it in India, then we can crack it in England and vice versa. But I think that's more of a universal human problem rather than a country-specific one.
I have a question. What is the current status of NICE guidelines on inclusive of PCSK9? Because now we are going to have the generic one available very soon at very low cost. So, do you think we will be able to replace it with statins in terms of, and would you like to call it a heart attack vaccine?
It's a very good question. So those in the room, so inclisiran is one of the class of drugs called PCSK9 inhibitors. There's 2 types. One's an antibody, one's an mRNA, a bit like a COVID vaccine. It's been around. We're still waiting for the outcome trials to come out for that, but NICE has approved it to use in the UK. Just for context, privately in the UK, if you try and get this injection, it's about £10,000 a year. Private. NHS got it to a substantial discount, and if it's going to be a low-cost option, that would be fantastic. So the drug it's given as an injection every 6 months, and so that's why it's called a vaccine. Meaning that you can give it and you don't worry about patients taking the medication; they just take the next one at 6 months. And it's approved in the UK if your LDL is over a certain threshold. With cardiovascular, you can't take all these other medications. There's a bunch of criteria. So we at BARS, we've got a few hundred people on it now. It is effective. It doesn't take away the need for tablets. You still need to take something because it's more effective than taking away other medications. I think we are moving towards this kind of less frequent treatment option.
Yeah.
And what you touch on is an important question, because the next step beyond that, again, I'm going to say that's something we're going to do in India or in the UK imminently, but it's gene editing. Where we're going more and more upstream in the gene transcription pathway. So actually, let's just stop it at source. And there are gene editing studies now where we can silence, completely knock out a base in the PCSK9 gene, which means that there's lifelong 50% reduction. You can see that's a really attractive concept from an adherence perspective, because you're done, one and done. So I think if a low-cost inclisiran option is coming, that will certainly help. But then you still need to figure out the logistics of how you're going to make sure that people keep coming back for injections.
Yeah, I have two questions. One for Dr. Reddy and one for you. Dr. Reddy, do you think abdominal obesity that we see in many men, especially in the south, have you studied the correlation between that and heart problems? Because I'm concerned that every traffic policeman has got a huge brain. So I've often wondered whether we have.
Ma'am, actually, it's not just in men, also in women as well, particularly postmenopausal. Abdominal obesity, or visceral adiposity as it's called, has acquired far greater importance over the last 3 decades. Previously, the focus used to be mainly on general obesity as measured by body mass index. Now, body mass index, while it has been widely practiced and used for all kinds of risk scores, is an unsatisfactory measure, because it actually gives a ratio of height to weight without necessarily adjusting for where the weight is coming from, whether it's coming from the muscle, the bones, or the fat, or even the body fluids. So BMI has been found to be not a very good predictor now, and it's actually losing its relevance in most international guidelines. On the other hand, visceral adiposity or abdominal obesity, where the fat collection is mostly within the abdomen, mostly around the liver and the abdominal organs, that actually is much better correlated with inflammation, with glucose intolerance, with dyslipidemia, and a number of other cardiovascular risk factors, and is now known to be a much better predictor. Previously, for that, the waist-hip ratio used to be used as the measure. But again, that's difficult sometimes, because the hip measurement is not always easy to standardize, especially in women, and even in Indian circumstances, sometimes it's difficult. But a much better measure has emerged now, called the waist height ratio. Initially introduced in children, it's been now validated even in men and women, adults, and a waist height ratio is probably better than a waist hip ratio, and certainly better than BMI, and now is being incorporated in many of the guidelines, including the NICE guidelines. And simply put, a waist height ratio of more than 0.5 spells trouble, whether in men or in women. Waist height ratio. So we ought to be able to use this kind of thing for risk stratification in the community very easily, without even getting people to do all kinds of hip measurements. So that's a tailor-made measure, if I may say so. But we need to definitely ensure that the interventions to reduce abdominal adiposity, whether it's the nature of our diet, That means less of refined carbohydrates, more of unrefined carbohydrates, more of green leafy vegetables and so on, less of ultra-processed foods. All these are going to become important dietary interventions apart from physical activity. Even smoking increases abdominal adiposity.
Yes. I mean, it's a $1 million question. It's been studied for decades now. So into Western nations, particularly kind of people who've moved over, we know that that risk is manifest. But a lot of the same things that we've talked about. So there is a great predisposition to diabetes, insulin resistance, which is where we think most of the root difference leads from. There's other things like we have slightly smaller coronary arteries. That there's a few other subtle differences. But I would say, on the whole, if you ask me for one primary reason, it's going to be that insulin resistance axis, which is primarily the driver. It's insulin resistance, meaning the kind of underlying basis of metabolic syndrome and diabetes.
This has gone through multiple phases in which they talked about genetic predisposition. Then they talked about, there was also the so-called thrifty gene hypothesis, thrifty phenotype hypothesis of David Barker, which said that if you're small bone and metabolically programmed to conserve weight, then your muscles use up less of glucose because you want to spare it for the brain, and then you grow into a different nutrition environment, and then there's a physiological mismatch, and then you start getting more nutrition, your muscles are insulin resistant, and then you get diabetes. All of these have been gone through, but we've also seen in large epidemiological studies, if you take urban rural Indians, there's a lot of difference in terms of risk propensity. Similarly, if you take migrant Indians in different countries, they have been at a higher risk than Indians in India. So it's been shown that some of the classic risk factors do operate very much when you look at interpopulation differences, whereas within population, some of the novel risk factors stand out to be much more prominent because there the environmental exposure is common. It's the gene factors which start sparking up attention. But the important element is, just to give you one case, Shah Ibrahim, who worked with us in PHFI for some time on a sabbatical, and we had done a 10 factory study, industrial population across India, including families. But he selected 3 industries, and in each industry we had studied more than 5,000, up to between 5,000 and 10,000 people, and looked at workers who had migrated from rural areas and 5 years of migration, and compared them with their rural siblings who had not migrated, stayed back, and showed that within 5 years, the acculturation was so much that every single risk factor, behavioral as well as biological, from glucose intolerance to body weight to waist-step ratio to every single type of measured risk factor, cholesterol and everything else, had markedly increased in the urban siblings, which had almost reached the urban levels of people who are long-time resident there. So instead of blaming the genes we share, perhaps we should look at the genes we wear, whether we're still fitting into last year's genes or not. Of course, environmental air pollution has definitely been shown. Firstly, not only to increase blood pressure. In studies in Delhi, it's been shown that if you live close to a highway, as opposed to farther away from a highway, there's at least a 7 millimeter difference in the systolic blood pressure. And more importantly, air pollution destabilizes the atherosclerotic plaque. The stable plaque breaks down, becomes the nidus for the large thrombus, and therefore your risk of stroke goes up, risk of heart attack goes up. Air pollution is a major issue. Lead too, but lead has not been studied that much in adults as in children.
Yeah, I mean, just to add to, I think we spent the last 30, 40 years finding more and more risk factors. I think what again is one of my reflections is that a lot of what we're fighting is societal structures and urbanization and capitalism and all the things that we talk about, right? It's, why aren't we tackling the food industry? Why are we trying to solve the obesity crisis with injections instead of actually talking about why we're selling processed foods to the poorest and the most vulnerable? So I think a lot of things that affect cardiovascular disease also affect all other diseases and conditions. So I think these are probably bigger challenges than in this room at the moment.
Yeah. Thank you. So I know there's more questions, but we need to move on to this. There'll be further discussion at lunchtime. So we're moving to the second session, which is on infectious diseases. And so we're going to cover a wide variety of things, including methodologies. But in terms of infectious diseases, although we've seen decreases and shifts in India, for example, in terms of non-communicable diseases becoming more important, we've certainly seen from the impact of COVID that new diseases can have huge impacts still. So we're going to start with a talk from Professor Richard Hayes from the University of Oxford on the recovery trial treating COVID, and then we'll move to a talk on tuberculosis, which is a recurrent infectious disease theme. So, thank you very much, Richard.
Invitation. So this is going to be something completely different from what we've just been hearing about, and something I'm afraid is going to take us back a few years. The topic I was given was to talk about novel infections. As a health warning from my talk, you'll see I'm not an infectious disease specialist. I'm actually a nephrologist, a kidney doctor by training, and I ended up involved in this particular project pretty much by chance. Novel infections, emerging infections are always with us. We're very familiar with SARS-CoV-2 as it became known in 2020, but if you look back over the previous decades, somewhere in the world there's always an emerging infection around causing problems. Fortunately, only very rarely do they develop from local epidemics into global pandemics. The background of research in the epidemic setting hasn't been terribly good in the past. What we see is as soon as an epidemic emerges, there are very effective public health interventions put in place very quickly. There is then a research response, but typically the research response really doesn't gain momentum until the epidemic is pretty much over. And if we look at previous epidemics, either influenza or other coronaviruses, we can actually see that the number of trials that managed to get going before the end of the epidemic has been very small. The information has been very limited, and we haven't really learned very much about how to treat these diseases before the disease disappears. But if we go back to the start of 2020, I'm sure many of us will remember this. I've put on there some graphs of cases in the UK and India at the start of 2020. And we had far too many people being admitted to hospital with chest x-rays, as you can see there, very inflamed lungs, very sick patients many of them requiring intensive care, and very high mortality rates at the start of 2020. So this was clearly a massive problem for health services and populations around the world. And nobody really knew what to do. There was a huge amount of therapeutic uncertainty at the time. There are many different drugs and treatments that were being proposed. Very many strong opinions were being made, but actually there are very few, if any, reliable data. So we had populist leaders proclaiming very clearly what they thought might work. Donald Trump famously recommending bleach as an option for COVID. Or Jair Bolsonaro from Brazil, firmly of the belief that hydroxychloroquine he'd taken when he got COVID was responsible for his recovery. And the best information that we had at the time were uncontrolled, non-comparative observational studies of a small number of people. So really nobody knew what to do with this novel disease. So what we wanted to do when we set up the trial is we went back to what the principles of this trial needed to be. We were adamant that the trial, for a start, must be randomized. There was very little value in non-randomized data at this point. We needed to eliminate the systematic biases that you get in such studies, and therefore we wanted to randomize people. And we also wanted to make the trial as large as possible to make sure that we could minimize the random errors so that they wouldn't obscure or even inflate estimates of treatment effects. So those two are the basic tenets of any assessment of any treatment, really. The added challenge in the pandemic setting was the trial needed to be quick. We needed to make sure we recruited as many people as we could, so before the first wave of the epidemic faded, so that we knew how to treat any subsequent waves that emerged. And as we're very familiar, there were many waves of COVID. And in order to ensure that we could do the above three things, we needed to make the trial as simple as possible, so that it could be delivered. So it could be large, it could be quick, and it could be delivered by healthcare systems that were already under considerable strain and possibly at breaking point. So this is how the recovery trial started. It's a platform design, so it wasn't just testing one treatment versus control, but we were testing multiple different treatments against a shared control group. We kept the eligibility criteria as broad as we could. We started off testing adults. I'll tell you later, we effectively removed any age restriction later on in the trial. Mere qualification was you needed to have been admitted to hospital and needed to either have proven or suspected COVID-19. At the start of the pandemic in the UK, there were too few testing kits to actually prove that everybody going to hospital had COVID, but it was a pretty clear presumptive diagnosis. And then we compared a number of different treatments, which had been, before the pandemic had emerged, had been decided upon by a government committee that these would be the treatments to test in the case of a respiratory viral pandemic. And then we kept the outcomes very simple. So all-cause mortality was the primary outcome at 28 days after entry into the trial. And then we collected information on a few other outcomes, but not very many, looking at healthcare usage primarily. So that's how recovery started in 2020. I thought I was going to help on a trial and be working on it for a few months, and then I'd go back to my normal day job. Didn't quite turn out that way. Now the trial is now finished testing treatments for COVID. During that time, we tested 16 different treatments, either directed against the host response to the viral infection, directed against the virus itself in various different ways, or directed against some of the complications of the virus. And you can see on the bottom there, that's actually our recruitment graph, the number of patients that we recruited every day into the trial, which pretty much mirrors the waves of infection that we saw in the UK. And you can see the various viral variants going across the bottom there. And it's all of those comparisons have now finished, and we've produced a large number of results. Most of the results have been showing that the treatment didn't work, which, although may be disappointing, actually is a very important answer, particularly when some of those treatments either came with side effects or were costly or were simply just difficult to implement for the healthcare service. It meant they could reject them and focus on things which either did work, were shown to work, or might work in terms of putting patients into trials. So what I wanted to talk about recovery is some of the lessons I've learned. One of the key ones was keep it simple. Maybe not the sort of thing you want to hear at a joint meeting of the Royal Society and another national institution of science, but we kept it as simple as we could to make sure that things would work. So as I've already told you, the eligibility was simple, the outcome was simple, the randomization process was simple. That took about 7 minutes to do on average, because we were measuring that quite carefully. And we collected follow-up information, but as a limited amount. Everybody had their favourite outcome they wanted us to collect, but we really focused on what we thought mattered. And that allowed us to be fast. So we recruited the first patient 9 days after the protocol was finalised, and we got the first results out of the trial just 78 days later. And it allowed the trial to be large. So during its time, and I'll just show you, hopefully start this video, showing the sites opening up in the UK, we managed to recruit over 48,000 patients into this trial pretty rapidly. And that allowed us to make the trial inclusive. So we recruited over 100 pregnant women into the trial, the group that are all too frequently excluded from treatment trials. As I say, we removed the age range. The youngest patient who went in was actually a baby who was born 8 weeks premature. The oldest was 103 years old. We included 237 children overall. And based on the UK population, we got a pretty representative population of the people hospitalised with COVID. So these are some of the lessons that I've learned. The first was that we need to demand, in such situations, we need to demand and then ideally supply randomized evidence. At the start, randomization was not universally accepted. There was a lot of pressure on people in charge of the response simply to treat and observe, but not to include randomization in that. And you can see this is one of the letters that was sent to one of the chief medical officers saying that we shouldn't just put people into trials. Everybody should be offered drugs and we should just simply follow them up. And as you can see there in blue, they thought there was no safety issue, something which unfortunately proved not to be true. So we were battling against that. One of the things that I've learned in my career, it actually comes from the cardiovascular field. This is the first trial I ever worked on, but I think this is a really good example of why we should demand randomized evidence. So the first trial I worked on was assessing a drug called niacin, vitamin B3, as a treatment in secondary prevention of cardiovascular disease. So that fits in nicely with the previous talk. It had been used for over 50 years, and it still is used quite a lot in America in this context. But it had never properly been assessed in a trial, particularly since statins have become available. So that's what the THRIVE trial did. And on the left-hand side, you can see that the drug is ineffective. It had no effect on major vascular events in people at high risk of them. So the drug's ineffective, but what was worse was what you see on the right-hand side is the adverse event profile that we determined, which confirmed some of the known side effects of niacin, but also discovered some new ones. So actually niacin, once these data became available, was taken off the market by the manufacturer that we'd worked with. But it just goes to show that drugs can be used for 50 years and you can have harms that you didn't know about. So trials really are essential. The second thing I learned about was the importance of challenging dogma. So this was a letter that rather unfortunately we received just 6 days into the trial, when things were quite stressful, as you can imagine. 19 professors, I don't know if there are any fellows of the Royal Society amongst them, but they wrote to the chief investigators of the trial quite a long letter saying that we should not be studying the drug dexamethasone. And the reason they gave, I've just highlighted it in there, we don't believe it's ethical to randomize patients to dexamethasone, a treatment where there is a large body of prior evidence to suggest likely harm. We were fortunate we were allowed to challenge that dogma, and these were the results we saw with dexamethasone. So the first treatment shown to reduce mortality in COVID-19, emerging at a time when there was still actually great uncertainty whether we would be able to have a vaccine or not. So this was a huge boost, I think, for health systems around the world, and really interesting. The drug certainly worked, but it worked differently. And what was the nice thing about dexamethasone was that the sicker you were, the more benefit you got from the drug, both in relative terms and absolute terms. So this drug went on to have a major impact. We managed to coordinate the results of the release of these results with the MHRA and the Department of Health, such that just a few hours after these results were announced, national guidance was published and doctors were prescribing that drug immediately. But it was really important to challenge that dogma. The third lesson was really that randomization should be part of high quality clinical care. I think all too often we consider clinical care on one side and we consider research as something completely separate to it. Actually, the two should be very closely integrated. So as an example of this, I want to talk about convalescent plasma, which is a treatment we went on to test during the second wave of COVID in the UK. So convalescent plasma has been used as a treatment for viral epidemics for over 100 years. The idea being that you take plasma from people who've recovered from the infection, which should be rich in antibodies against that infection, and then give it to people who have just presented for the first time with the infection to give their immune system a bit of a head start, if you like. In the US, they have spent hundreds of millions of dollars on collecting convalescent plasma, processing it, and then delivering it to people hospitalized with COVID, and they never included randomization once. They've published non-randomized studies suggesting that people who got stronger convalescent plasma, in other words, with a higher titer of antibodies, did better than those who didn't, just comparing outcomes in about 3,000 people. By contrast, the UK, when our National Blood Service started developing convalescent plasma, we spent a few £1 million comparing in a randomized way what happened to patients given convalescent plasma versus those who didn't. And we did that in over 11,500 patients. As you can see, two survival curves there which effectively overlie each other. Absolutely no benefit found with convalescent plasma, which then meant that the National Blood Service didn't invest tens or hundreds of millions of pounds into a convalescent plasma collection, processing and delivery service, saving that money for more useful things. I'm going to come back to challenging dogma again. This is like convalescent plasma, but now with a bit of a boost. So these were some drugs that were developed during the pandemic where they refined antibodies from people who survived. Actually, some of these antibodies came from people who survived the original SARS-CoV-1 virus, and then started producing them with monoclonal antibody techniques so that you could give very much larger doses of antibody. However, people were telling us there's no point testing this in recovery because by the time you get admitted to hospital, it was already known that the viral load was falling in patients typically by the time they came into hospital, so an antiviral therapy may not be beneficial. And also, we know that it's the inflammatory response that's killing people. It's not the virus. By the time they get into hospital, it was the inflammatory response. And we'd shown that treating that with dexamethasone worked. So we recruited everybody and we made the trial just a little bit more complicated. And we collected a blood sample before we randomized people. And on the basis of that blood sample, we could break people down into two groups. Did they have their own immune response to the virus already in their blood? In other words, were they seropositive, so they already had their own antibodies, or did they not have their own antibodies? Were they seronegative? And we hypothesized that actually giving those seronegative people this boost of antibodies might be particularly beneficial. So you can see here that whether you're seropositive or seronegative is actually a pretty profound prognostic marker. People who are seronegative were at much higher risk of death than people who are seropositive, but it also predicted your response to therapy. So the seronegative group got a 20% reduction in the risk of their death when we gave them antibodies which they didn't already have, in contrast with the seropositive group who didn't get any further benefit. Really good lesson in science. Unfortunately, the virus beat us though, because the virus then just mutated and the next variant was no longer sensitive to these antibodies, and that race against the virus has been continuing since. Another lesson is that in trials, size really does matter. So tocilizumab was a very popular drug, particularly when the pandemic reached Italy. There's a lot of tocilizumab being used. This is an anti-IL-6 monoclonal antibody, so it's very profoundly anti-inflammatory. These were all of the trials prior to our results becoming available that have been done looking at tocilizumab. And you can see from the width of those confidence intervals in this forest plot that there is a huge amount of uncertainty, really. And even when you put all of those data together, you still had a non-significant result overall. So we didn't know after these trials whether tocilizumab was worth the £1,000 or so a shot that it was to give. However, we were fortunate that the manufacturer gave us 2,000 doses of the drug to test in recovery. And so we did. We randomized 4,000 people between tocilizumab or not, and we demonstrated a clear 15% reduction within recovery overall. And then when you update the meta-analysis, you see that that's a very clear benefit from this treatment, even when added on top of steroids. So size really does matter. The small trials were not giving us the information that we needed. They weren't changing practice. You needed a big trial to give a clear answer. This comes back to one of the questions that we had after the last lecture, was about routine data and what's available. In the UK, we're very fortunate, and there's a huge amount of routine data available, and we were particularly fortunate in recovery in that we were given ready access to it. So we had data on hospitalizations, why were people in hospital, how long were they in hospital for, mortality data sets, including cause of death. We had disease-specific data sets, including my favourite, the UK Renal Registry, primary care data sets, critical care data sets, and some data sets that were set up just for COVID. And we were able to link all of these together for our patients. So we actually linked our patients to more data sets in recovery than participants in UK Biobank have been linked to. And that allowed us to do a lot of things. With that, when we first started the trial, we weren't sure we'd be able to recruit. We got over that fairly quickly and recruited very rapidly. The next question was, were the hospitals going to be able to give us the follow-up data? And this is where linkage came in, because if the hospitals couldn't provide it, we could have got the data from linkage. As it happens, the hospitals did a fantastic job. I've already said that these routine data, it's very tempting to use them in non-randomized comparisons because they make them very easy, but we didn't think that would add any value. But when you mix routine data with randomization, you get a very powerful combination. What I'm showing you on the picture here is for some of the major results that we've had. I'm showing you the result whether we only use the data that we collected from the hospital sites, that's the case report form data only, or whether we only looked at the data that we got from linkage, that's linkage only, or whether we use the combination that we pre-specified where we put those two things together and came up with algorithms for deciding how to resolve any discrepancies between them. But what you can see is effectively it didn't really matter. The case report form data, the linkage data, or their combination all gave the same result. So it's a really powerful tool. And it's the tool that doesn't stop giving. So it's allowed us to follow up these patients for much longer. The primary outcome I told you was death at 28 days. This is what happens if you follow up people for 2 years through linkage. And this is really reassuring for me because there was always a concern that a lot of the immunosuppression that we were giving people may then come back and bite them a few months later if they were to die of complications such as infections or cancers from the immunosuppression. And you can see here that that doesn't happen. If we kept them alive during the first 28 days, they maintain that survival benefit for at least 2 years. So all of this has been possible because recovery embraced streamlining. It allowed the trial to be fast and large and inclusive, and it also allowed us to do the trial incredibly cheaply. The cost per patient of people going into recovery was only a few £100s. What is streamlining? Well, it's not collecting absolutely everything, but it's really focusing on what matters in a trial. Keep it as simple as you can and only add complexity when that will add value. Some people think that streamlined trials is fine for academia, but it's not going to change regulatory opinions. This was a piece written by, at the time, the person in charge of the US FDA and some of his deputies. And we loved it. He wrote this, we didn't have to give him the quote. He wrote that streamlining and quality are not opposed, which is really fantastic for other trials that want to use similar methods. There's quite a lot we can learn from recovery for other trials. Pandemics, I almost call this trial trials in a crisis because that has a double meaning. Recovery was a trial in a crisis situation, but trials themselves are also in a bit of a crisis. There is still a pressing need to identify new treatments, but trials are becoming excessively burdensome and unsustainably expensive. And a large part of that is due to inappropriate regulation or the inappropriate interpretation of regulation. If we look back and see some of the implications of the trials crisis, even during COVID, only 5% of the trial arms that were done of all the registered trials, this was an analysis done by the FDA, actually had a reasonable chance of achieving a meaningful result. So there's a huge amount of waste going on in trials. Trials really struggle to recruit, and the cost of trials, as I've said, is already going up. And this means that the standard of evidence that we have on which to base treatment decisions is quite poor. Cardiovascular disease, which has a pretty strong evidence base, even if you look at their guidelines, only 15% are based on high quality evidence. It means that we don't get the treatments that we need. It means that we either don't test treatments that might work, or that treatments that do work aren't fully utilized, that we may find one niche indication for a treatment, but it may have much wider benefits, or we don't fully understand the effects in all the relevant groups. So one thing that we've been involved in Oxford is the development of better regulation. and we've worked in collaboration with a group called Good Clinical Trials, and they've recently released their own guidance for trials, which has been adopted by the WHO. And that does focus on the key principles, unlike some of the other guidance documents which are around. So as a finish, what's recovery doing now? Well, it's not just in the UK. Before the second wave of COVID, we'd expanded to a number of other countries, including India, where we work quite closely with the Indian Council for Medical Research. But we're now testing treatments for severe influenza, antiviral treatments, and you guessed it, we're testing dexamethasone again, and also for community-acquired pneumonia. So recovery is a trial which continues, essentially so that we're ready there if there is another pandemic. So what I've hopefully shown you from recovery is that arbitrary use of unproven treatments is damaging to patient care and to public health, and randomized trials are possible in such situations, and they can become and are a critical component of high quality clinical care, which can be delivered alongside routine care. The compelling results that we got in recovery and trials like it change practice, but to do that, it really does need a focus on what matters, keeping the trials simple. So I'll just finish with some thanks. At the top left is the group of people who met at Oxford University every day to sort of plan the trial and work out what today's challenges were and how we were going to solve them. Some doctors and nurses from one of our sites in Indonesia looking far too excited about taking part in the trial. Some of the steering committee at the bottom left, but the people we always remember at this point, at the picture at the bottom right there is John Hanna and his wife. And John Hanna went into hospital with COVID early on in the pandemic, and his wife saw him off in the ambulance and thought that might be the last she saw of him. She got a call in the evening and to tell her that her husband was going to intensive care. He was quite unwell, but do you think he'd want to go into a trial? And she said, absolutely. He was given dexamethasone, and he's been ever since been one of our strongest advocates for trials in these situations. And without people like him and families like that, we could never do trials like this. So thank you to them too. Thank you for your attention.
Thank you very much indeed. So again, we'll wait for questions until we've had both the talks in this session. So we're going to switch from a new disease to one of the old classics, so tuberculosis, which is still an ongoing problem in many countries. It may be at particular risk populations that are more affected, but it is an ongoing public health issue. So Dr. Satyana Rayana is going to speak to us about India's TB burden in particular. Thank you.
So good morning, everybody, and thank you for giving me an opportunity to speak on this occasion. My name is Dr. Srinath Satyanarayana, and I am the director of ICMR, National Institute for Research in Tuberculosis. Our institute is located in Chennai, the southern part of the country. Now, for those of you who may or may not be fully aware of what tuberculosis is a disease caused by Mycobacterium tuberculosis, which is a rod-shaped bacteria, aerobic bacteria, and one of the most important characteristics of this bacteria is it multiplies very, very slowly. When compared to, for example, Escherichia coli, which doubles every 20 minutes, this takes at least 24 hours to double under ideal conditions. Tuberculosis is an airborne infectious disease that primarily affects the lungs, but can also affect other parts of the body. The bacteria are spread through air when person with lung disease coughs, speaks, sneezes, and others nearby breathe them in. And the disease is chronic in nature, the onset of the disease as well as the progression of the disease, and treatable with medication, but it can cause death if left untreated. So the most characteristic feature of tuberculosis is the lung. When it affects the lung, it causes cavitation, and that is one of the pathognomonic feature of tuberculosis. Now, our current understanding of the pathways of TB infection has still been evolving. So once the person gets infected with tuberculosis, there are several understandings and theories about how the disease progresses, and this is one of the latest ones that we have in the field. So anybody who is infected with tuberculosis at the start of the infection can move into three different pathways. One is, either it can develop into primary tuberculosis, immediately goes on to develop the disease. Predominantly it happens in children as well as those with immunodeficiencies like HIV infection. The other pathway is TB infection can get eliminated in case if the body's immune reaction is very, very powerful. And the third pathway is it can go into latent TB infection where the bacilli is dormant, not multiplying. The immune system has contained the bacteria, but after a certain period of time, it can undergo activation whenever the immunity in the body comes down. And this rapid reactivation can happen and people can develop the disease. And the other pathway that we all thought was this pathway where there is going to be a slow reactivation, which is seen predominantly in most of the Western countries, where the TB disease is seen predominantly among older individuals because of the slow reactivation, the infection that they have acquired somewhere long time back, which is getting reactivated. This is the pathway that is there, or in majority of the individuals, there could be a slow elimination of the infection, or it can continue as latent TB infection where the individual has the bacteria but it is not actively multiplying. The other interesting pathway that we are recently discovering is the cyclic in nature, okay, where there is, this is the threshold for developing of symptoms. The bacteria is actively multiplying, individuals develop the symptoms, but then it is not a one-way kind of thing. They can go into remission and then once again they can come back. And then, the cyclical nature of the disease is what we are trying to understand. And most of the earlier, most of the attempts that we've been making in the field of tuberculosis is in terms of secondary prevention is early diagnosis and treatment. So most of our early diagnosis was focused on those where there was an onset of symptoms, identify these individuals and treat them with medication. So that was one of the core principles. And when I started working for tuberculosis way back in the early 2000s, when India was implementing the revised national TB control program, the two main objectives that we had was one is detection of at least 70% of the cases, and then successfully treating 80% or 85% of the cases, with the understanding that most of the people develop the disease in case if they are infected and if they have multiplying bacteria, and therefore diagnosing them and treating them is going to be one of the most important ways to control TB disease in the country. But then our latest understanding is that when people are having all these bacteria multiplying and active, people are transmitting the disease here in this stage as well. So if we are just focusing on those who develop symptoms in order to identify TB cases and treat them, maybe we may be able to identify individuals who develop overt disease, but when it comes to reducing the TB transmission, that may not be adequate. So this is the understanding and development that we have, and there's a lot of speculation about what proportion of patients move into these different pathways, and in different geographical areas and in different population groups, and even within our country in different areas, the proportion of people who get infected who move into different pathways is quite different. Okay, so that is the whole difficulty that we have with respect to the control of tuberculosis disease. So what type of strategies should we use? Whether we should focus predominantly on early diagnosis and treatment in case if it is early diagnosis. How do we approach this early diagnosis? Do we catch them at health facilities, or should we go to the community and identify individuals who may be having symptoms? Or should we also try and attempt and identify these individuals who do not have the symptoms yet, but who may be transmitting the bacilli through their air? So these are some of the issues that are really grappling, and this is where some of the scientific work that we are doing is currently focusing upon. Now, coming to the history of tuberculosis, unlike some of the diseases or viruses that my previous speaker spoke, tuberculosis disease, if you see the genus Mycobacterium tuberculosis, it came onto this earth almost 150 million years ago. So that is when the entire genus came in, and there are 190 different species under this genus, and Mycobacterium tuberculosis is one of that. The other one most commonly that is available in the species is Mycobacterium leprae, which most of you must know, and it is still an unfinished business in the country. And then the infectious disease, the bacteria was isolated way back in 1882. Okay, so this is almost 143 years back. The bacteria was identified, and then from then its identification till date, it is estimated that more than 1 billion people on this earth have succumbed to this disease. And the disease was uniformly common, not just in Asia, but also across the world. Even in the developed countries, if you look at their medical records, you will see that most of the developed countries as on date were also having a big TB problem. But most of the TB they were able to address because of improvement in the socioeconomic status, improvement in the nutritional status of their populations, better health systems for early diagnosis and treatment, and also the availability of drugs that came up during the course. But right now the situation is that TB still continues to be one of the major infectious disease killers in the world. So this is from the latest global TB report, which was published a couple of weeks back. You see the estimated number of TB deaths due to tuberculosis is still 1.08 million, way above any other infectious disease. The reason why this does not catch global attention or global news media is because the disease is not as acute as any of the other infectious diseases so as to cause an alarm. It is chronic in nature, sporadic, distributed widely across, and therefore, we do not talk much about it, at least in the mainstream media, even though this is one of the major infectious disease killers in the world. Now, where is the TB disease concentrated predominantly? So 8 countries contribute 67% of the global TB burden. You can see what those 8 countries are: India, Pakistan, Bangladesh, Indonesia, China, Philippines. These are the countries in the Asia, and then you have Nigeria and Democratic Republic of Congo. And India still continues to have the largest burden of tuberculosis. Almost out of the 10.7 million cases that are there globally, 2.7 million cases are in India. That's almost 27 to 28% of the global burden is in India. So what is Government of India doing to address the TB problem? So we have a national TB elimination program, which we had one national TB control program since 1962 onwards, which was predominantly focusing on diagnosis and treatment. And then diagnosis and treatment also, there were a lot of deficiencies in the way in which we were diagnosing, predominantly based on chest X-ray, and treatment also was not standardized, and it was not being provided appropriately the full dose of treatment that is required. And therefore, in 1997, Government of India launched the revised National TB Control Program, incorporating the global DOTS strategy. Okay, so that program functioned till 2020 onwards. And in 2017, when the government was looking at the national TB program and also revising its strategy for the national TB control program, then we had this sustainable development goals in front of us, and TB had a couple of indicators, 3 indicators in that sustainable development goals. And this included 80% reduction in TB incidence from 2015 as the baseline, 90% reduction in TB mortality, and 0 catastrophic cost to TB for patients and households. So catastrophic cost is considered when, say, for example, a family who gets TB disease spends more than 20% of their household income in accessing the services. So that is considered as catastrophic cost. So we wanted to achieve 0 catastrophic cost due to tuberculosis, and at the same time, we wanted to reduce 2 things. One is 80% reduction in incidence and 90% reduction in TB mortality when compared to 2015 as the baseline value. So when this whole program was presented to the Prime Minister of India, so he gave us a challenge. He said, why should we wait till 2030? So why can't India achieve this 5 years ahead? Whatever is needed to achieve this reduction, why can't we do it in 2025 itself? And that was one of the challenges that was given to us. And in fact, in 2017, when Prime Minister was invited to TB symposium, he made an announcement that though globally the aim is to reduce TB burden by 2030, but we will try to achieve it by 2025. And of course, we didn't do that. Several reasons contributed to that. Most importantly was the disruption in the health services that happened due to COVID between 2020 to 2025. Our case finding came down dramatically, and some of the programmatic efforts that we were made went into disarray, and therefore there has been some kind of a resurgence of tuberculosis. Nevertheless, we've made significant achievement. So the National TB Elimination Program is guided by the National Strategic Plan, as I said, which was formulated between 2017 to 2025, and this had 4 key pillars. One is detect, treat, prevent, and build. And the objectives of the program is about early diagnosis, then engaging patients seeking in the private sector. That was the second thing. Prevention strategies include contact tracing in high-risk vulnerable populations, airborne infection control, and multi-sectoral response for addressing social determinants. So it is at this stage when the symposium was announced and my lecture was provided, I reached out to Dr. Soumya Swaminathan to understand whether I should speak about secondary prevention in terms of what the Government of India is doing for diagnosis and treatment, or should I modify it. She asked me to focus on primary prevention in tuberculosis because this is an under-discussed and under-researched area. And she asked me to highlight some of the issues in primary prevention, and therefore I will speak about that. Now, before I get into that, trends in TB disease burden in India, 2010 to 2024. As you can see, the disease burden, as it's seen in the green line here, this is the estimated disease burden. Initially, we had a lot of uncertainty, and now, thanks to the TB prevalence survey that we did in between 2019 and 2021, it was a massive exercise done across the country, and this prevalence survey has made our estimates much more precise. And this line, the dark line that is here, this is the number of cases that we are able to detect against the estimated number of cases. So as you see, initially to begin with, we had a large gap between the number of estimated cases and the number of cases that we were able to diagnose and treat. But off late, we are catching up. 2020, there was a dip, but off late, we are catching up. And right now, the treatment coverage is approximately 92%. Similarly, the estimated number of deaths due to tuberculosis in the country is also coming down, but not at the level that we would have desired. As I said, we did a TB prevalence survey. This was a massive national level exercise, and the findings of the survey is available. So, few important findings that we learned from the survey. First is the TB disease is not uniformly distributed across the country. There is a huge statewide variations. Delhi, that we are living, has the highest TB burden. 700, almost 534 per 100,000 population in the country. And then the lowest is in Kerala, the southernmost part of the country. But there are a huge variation. So this variation is something which we'll have to accept, and we have to fine tune our intervention strategies, taking these variations into consideration. The second important finding that we got to know from this TB prevalence survey is that there is a gap between this is for males and this is for females. The prevalence is higher among males across all the age groups, and when compared to the females. And the next important finding is that the prevalence of tuberculosis increases as the age advances. So elderly population have a much higher risk of tuberculosis in India than when compared to the younger population. And then the other important estimate that we came to know during the national prevalence survey is the prevalence to notification ratio. That is, at the community level, what was the number of prevalent cases that we had, and out of that, what cases we were detected and treated when the survey was done. Okay, so the prevalence to notification rate was 2.85, which means that for every case detected in this particular geographical area today, there were another 2 or 3 undetected cases within the community. And most of those undetected cases were in those subclinical forms that we discussed. So asymptomatic TB was approximately 38%, which means that these are the individuals who did not have TB symptoms, but had chest X-ray lesions suggestive of tuberculosis when a chest X-ray was taken. And when we asked them to produce a sputum sample and test that sputum sample, those individuals had Mycobacterium tuberculosis in their bacteria. And in terms of what is the contribution of asymptomatic TB to TB transmission within the community? Okay, so we do not have direct estimates of that, but mathematical model suggests that approximately 68% of the TB transmission could be because of asymptomatic TB. But you must also note that there is a wide confidence interval, 27% to 92%. So which means that there is a significant contribution of asymptomatic TB to TB transmission. Okay, so that's the next important message that we got. So where are we in terms of progress towards NTB strategy 2025 milestones? So globally, we're all implementing the NTB strategy, the WHO recommended NTB strategy. All the UN countries are signatories to this, and whatever milestones have been given for this NTB strategy, these milestones are applicable for all the countries. And this NTB strategy is being implemented since 2015, and it is still to 2035. But at the same time, at 2030, there is an SDG goal, which is there, and the SDG targets are also provided here. SDG Sustainable Development Goals related to tuberculosis. So basically, by 2025, when compared to 2015, we had said that the reduction in the number of deaths compared to 2015, we want 75% reduction in the number of deaths. Incidence rate, that is number of cases per 100,000 population that's happening, we wanted a 50% reduction. And TB affected families facing catastrophic cost, 0. So unfortunately, in India, we do not have a national level survey to measure what is the catastrophic cost that is happening, and therefore this data is not available right now for us. But isolated, sporadic, studies that have been done clearly indicate that about 40 to 50% of the TB households, face catastrophic costs. That is, they spend more than 20%. But this is not a nationally representative data. We have not done that. But these are from isolated. But when it comes to reduction in TB incidence rate and reduction in the number of TB deaths, where are we? So this is the global reduction in TB incidence rate when compared to between 2015 to 2024, and there is a 12% reduction. This is in the Southeast Asia region, whereas in India we've done much better and we've achieved almost 21% reduction in the TB incidence rate. The milestone that we had for 2025 was a 50% reduction, and the milestone that we have for 2030 is 80% reduction. And now when it comes to reducing the number of deaths, globally 29% reduction is there in the number of deaths. In Southeast Asia, it is 23%, whereas in our country, India, we have achieved 28% reduction in the number of deaths when compared to 2015. So these are the two parameters that we have. Now, this is one of the mathematical models that was done when by Stop TB Partnership, which looked at between 2023 to 2030, that is immediately after COVID, because of the lot of disruptions that happened. What is it that we have to do in order to reduce the TB burden and achieve the SDG targets at least by 2030 because of the disruptions that happened? And I was part of this global plan to develop TB in my previous capacity. So if nothing is done, status quo is maintained, then this is the trajectory. Okay, so whatever current tools that we have with respect to diagnosis, treatment, if we optimally implement that, with almost near 100% coverage, this is the trajectory it would bring in. And in addition, in case if we have to achieve this kind of a trajectory, then they said we require new tools and technologies. This is where research is needed. And there is also a huge scope for preventive measures here in order to achieve the desired outputs. Now, what are the priority actions for prevention? So these are the 4 priority actions that we have identified as important from a prevention perspective. One is implement airborne infection prevention control measures in healthcare settings and high risk indoor places where people congregate, because the transmission is predominantly airborne. So we want to achieve high airborne infection prevention control measures. And COVID had shown us very clearly, how to do this, masking, physical distancing, and all other things, fast tracking people who are having respiratory symptoms, and several things were demonstrated, not just in hospital settings, but also in public places. And therefore, this is one of the key interventions that needs to be done. The second one is we have something called as TB preventive treatment. That is, people who have TB infection, in order to prevent them from developing tuberculosis disease, there are certain medicines that can be given which will prevent them from developing TB disease. So this is called TB preventive treatment. And this TB preventive treatment is to be given for those with TB infection and who are at high risk of developing TB disease. And the third important intervention was to deploy effective vaccines once such vaccines are officially recommended and available. Currently, at that stage, we did not have a vaccine. But based on our experience of developing novel vaccines very quickly from the COVID experience, we thought that some of the technologies that were used for development of those vaccines can be adopted within TB, and we will be able to come up with a vaccine. And therefore, a lot of emphasis on TB vaccine research has gained traction. And so we were very hopeful that these vaccines will be available as early as 2026 or 27, and these vaccines will be deployed in the field. And the last important priority action for prevention is address TB risk factors and social determinants. That is, several risk factors are there which needs to be addressed. Now, where are we with respect to all these? Where does the country stand? Now, airborne infection and prevention and control, there are these WHO guidelines which are available for infection prevention and control. It speaks about administrative controls, environmental controls, respiratory protection, and core components of IPC program. In India, we have our own guidelines on airborne infection control and in healthcare and other settings. But the level of implementation is something which we are not regularly monitoring. Okay, so we do not know, if you ask me at this particular stage, of the hospitals or of the public spaces that are there, how many of them are fully doing this. We do not have this information at this stage, but we do have the guidelines in place. So operationalizing these guidelines, making sure that these are implemented is one of the important priorities in this particular area. The next one is provision of TB preventive treatment. Now, WHO guidelines clearly says that these are the high risk individuals who should receive TB preventive treatment. One is people living with HIV. They are at the highest risk of developing TB disease. So all of them should receive TB preventive treatment. The second thing is household contacts of pulmonary TB patients who are bacteriologically confirmed. Okay, so this is the second group of individuals. So all individuals who are contacts of pulmonary TB patients should receive. And then there is also other high risk groups indicating other high risk groups as well, which are people who have silicosis, who have initiating on tumor necrosis factor treatment or dialysis, or preparing for an organ transplant or a hematological transplant, because these are people with severe immunocompromised status, and in case if they get exposed to environmental Mycobacterium tuberculosis, then the chances of developing TB disease is very high, and therefore these groups are recommended. And then we have prisoners, healthcare workers, migrants from countries with high TB burden, and homeless people with those who use injectable drugs. So Government of India has actually adopted these guidelines, and we have our own guidelines for TB preventive treatment. But the data on what proportion of these populations are covered is available only for these two categories. That is, people living with HIV and household contacts of pulmonary TB or bacteriologically positive. So these are the medicines. About 6 different drug therapies are available, which can be given as TB preventive treatment. And the first 3, the 6 to 9 month isoniazid, this was the one that was being practiced for a large period of time. Now these 2 regimens have been accepted in the country: 3-month weekly isoniazid and rifampicin, and 3-month daily isoniazid and rifampicin. So the only difference is this is a weekly dose and this is a daily one, and rifampicin is a long-acting rifamycin, and therefore this can be given as a weekly dose. So these 2 regimens are also recommended, and rifampicin generally is not recommended for children, and therefore in children who have TB infection but who do not have TB disease, this regimen can be given. And we have something called as a 6 months daily levofloxacin for those contacts of drug-resistant tuberculosis. So some of the drugs that we are using for the treatment of tuberculosis, isoniazid and rifampicin, there is a resistance that is getting developed, and people with these resistances are also offered treatment. In contacts of these resistant cases, they are offered 6 months of daily levofloxacin as the for TB preventive treatment. Now, coverage, prior to 2015-16, we were not systematically monitoring the coverage, but then once the guidelines and the recommendations came up, there was a massive spike in the coverage of TB preventive treatment among people living with HIV. And then household contacts, though we had guidelines, it was predominantly for children less than 5 years of age. And in 2020, 2022, or 21, the guidelines changed to cover all household contacts. And from that time onwards, there is an increase, and still we have not reached 100% coverage. It's somewhere around 40 to 50% coverage, but the coverage is increasing day to day, and therefore this is one intervention that is done there. And the coverage of TB preventive treatment among other high risk groups, though it is recommended by the program, but because we are not systematically documenting that, we do not have data on that. Now, when it comes to vaccines, traditionally we know that BCG, which was discovered way back in 1921, this is the only licensed vaccine currently available for tuberculosis. Provides strongest protection against severe childhood forms of tuberculosis. Okay, given as a single intradermal dose at birth under National Immunization Program, part of the Universal Immunization Program in India, and from the data that is available in the institutional deliveries, almost 100% coverage is achieved with a single dose of BCG vaccination. But BCG vaccination, as I said, protects only against severe forms of childhood TB disease. So it has got very limited effectiveness in preventing pulmonary TB in adolescents and adults. And therefore, individuals who have received BCG can also develop TB disease. And therefore, this is not highly effective. And this is the number of TB vaccines that are there in the TB vaccine pipeline. The Stop TB Partnership is maintaining this TB vaccine pipeline, and we have indications about at what stages of vaccine these are. Currently, our institute, we are predominantly involved in phase 3 trial. So we have done this VPM 100 trial, and MTB vac is also under discussion. And globally, this M72, this vaccine, global trial is happening, and these are the promising vaccines that may be available. But this vaccine, the trial results will be available in 2027, and in 2028, in case if the vaccine is found to be effective, then we may have this vaccine at that point of time. But our expectation that we will have a vaccine based on the COVID experience as early as 2026 is not likely to happen. And this is one area where we need some mechanisms and guidance. And the last one is about addressing the TB risk factors and social determinants. So if you look at the risk factors for TB infection and TB disease, from exposure to infection to disease and access to TB care and clinical outcome, there are several factors which play a role, which are outside the purview of, some of them are inside the purview of the health system, whereas many of them are outside the purview of the health system, like addressing poverty, overcrowding, nutritional status, and several other factors which are there. So from the TB control program point of view, these are considered as the biological determinants of TB disease in Indian settings. So we have certain biological determinants, we have behavioral determinants, we have socioeconomic determinants, and we have occupational determinants. So the ones that are recognized as biological determinants is old age. Okay, so of course it's not a modifiable risk factor, but people who are in advanced age, they are at very high risk of infection. HIV is another one. Undernutrition is another important one, and underlying medical conditions like diabetes, chronic kidney disease, chronic lung disease, or other immunosuppressive drugs patients on, these are all biologically high risk factors. In terms of behavioral determinants, we have use of tobacco and use of alcohol. And in terms of socioeconomic determinants, we have poverty, overcrowding, poor ventilation, hard to reach areas, migration, and congregate settings, and prisons. So people living in these areas. And occupational determinants, we have people who are working, doing mining work and quarry work, basically exposed to silica dust, and then construction work. So globally, there are 5 important determinants that are assessed for their contribution to TB disease in the country, and this is what is the contribution of these 5 risk factors for TB. HIV is not a major risk factor in India, as is seen in the African countries. In India, the prevalence of HIV is very low, and therefore this is not a significant contributor to TB disease. The 2 important significant contributors are, number 1, undernutrition, which is one of the significant factors, and then we have diabetes mellitus, which is another important significant factor, and diabetes rates are increasing in the country. With respect to undernutrition, our institute was involved in one of the trials that was undertaken called the rations trial. The study of this became globally popular, and now it is an accepted intervention that nutrition supplementation given to people at high risk for tuberculosis disease prevents TB disease from happening. So this was a trial that was conducted where household contacts were given a food basket providing 750 calories and 23 grams of protein per day per person for 6 months during the course of the index case TB treatment. And in those households where the nutrition was not given, the TB incidence was much higher, and cumulative incidence of tuberculosis in those households where nutrition was given was relatively lower. So the efficacy of this nutritional supplementation, that is 750 calories and 23 grams of protein, in preventing TB disease, all forms of tuberculosis, was 39% and 48% reduction in bacteriologically positive pulmonary TB patients. And therefore, currently it is a national policy to provide nutritional supplementation food baskets to the households of tuberculosis patients. And this is a dashboard that is being used to track what proportion of TB patients are receiving community support. This is the almost 1.18 million individuals or households are receiving this food baskets, and therefore their household contacts developing subsequent tuberculosis at a later stage, that is being prevented. Now, when it comes to other socioeconomic determinants of tuberculosis, these are the risk factors that are identified from the SDG framework as important for TB, which means that if we address these factors, then tuberculosis will benefit from that. So what are those? Addressing, for example, poverty, hunger, diabetes, HIV prevalence, alcohol use disorders, smoking prevalence, and then if we increase the health expenditure per capita, and then achieve universal health coverage, and then affordable and clean energy, and several of these issues, improvement in urban populations living in slums. So in case if these factors improve at the population level, then TB will also simultaneously benefit from those improvements. Okay, so whatever we do on these arenas will also help. So there is a framework called the multi-sectoral framework, accountability framework. This has been devised by WHO for ending tuberculosis, which encourages participation by different sectors for controlling tuberculosis. And India has our own national framework for action through multi-sectoral approaches for addressing that. But again, this is a framework that is available, but when it comes to operationalization and the data to indicate how well this is functioning, we do not have that. And these are also areas for research. So in summary, within our country, TB still continues to be a major public health challenge in India. Measures aimed at TB prevention is essential to reduce the burden. Optimal implementation of airborne infection prevention control measures is required. Provision of TB preventive treatment for those with high risk of TB disease needs to be provided. And we need to have some sort of a vaccine which can be easily deployed so that we can prevent TB disease from occurring at the population level. And any measures that address TB risk factors at the population level through multi-sectoral action will also have some major benefit on reducing the TB burden. So the question is, do we have intention? Yes, in the country we have intention. Do we have guidelines, framework? Yes, we have that. Is an attempt being made to implement these? Yes, we are making attempts to implement that. Have we achieved optimal levels? The question is variable. We have not done that. And therefore, how do we reach optimally, with all these preventive measures? A lot of research is needed, not just basic sciences research, but also operational and implementation research needs to be developed, and models have to be developed. And those are the areas that is required in the TB prevention arena. So thank you very much.
Thank you very much indeed. I mean, yeah, we've had a very different perspectives on infectious diseases, and showing how they can be impacted by other lifestyle, such as diabetes related things and undernutrition and the impact those have. So yeah, we're a little bit late in the schedule because we started late, but we've got about 15 minutes now for discussion, and then we will break for lunch. So are there questions? This is for either speaker.
That was done by your group in the UK, and we were able, whilst I was at ICMR, we were able to do a similar trial during the first wave on convalescent plasma by democratizing research and doing it in district hospitals and rapidly doing it. I think the key which has come out from your talk is rapid execution of trials, because randomized data is important. We all know it, but rapidity is important. And that is exactly what we need to keep that momentum, that COVID momentum for other trials that are being done. For example, the vaccine trials that we have to do for TB. And then I come, this was the comment. Then I come to the question to you is that your graph talked about TB going up with age in India, both in male and female. And do you think it is the protection provided by BCG, which wanes up at 20 years or 18 years, that we are getting it much later? Or what do you feel is the reason? And do you think do we need to give a redose of BCG, which many countries in Eastern Europe are giving that? Comment and.
Versus that. So BCG protection, it is not even up to 20 years. Like it is after 5 years, the BCG protection is not seen at all. Even at the younger age group, the protection was not seen, and the protection was seen only in preventing severe forms of TB. And therefore, even though with that limited, evidence, but averting severe disease, especially among pediatric population, was considered important, and therefore it became part of the national immunization program, and it continues to be so. So there are several, with respect to BCG revaccination. I think there is some sort of compelling evidence to indicate that BCG revaccination might help. And we wanted to conduct a trial. I think you're also well aware of that BCG revaccination trial. And during the discussion, it so happened that the National TB program, which was under pressure to demonstrate rapid reduction in TB by 2025, instead of conducting a trial on a small scale, they said we will conduct a nationally representative trial by randomizing districts into units for receiving BCG vaccination. So this trial, which started in 2023-24, 560 districts, we have 750, 800 districts in the country, 560 districts, 280 districts randomized to BCG, and 280 districts randomized to receive the normal care. So then they listed about 6 high-risk groups who would all be reached at the community level, and BCG would be provided for that. So 1.5 years later, when they looked at the coverage levels was not more than 10% or 20% of the eligible population. The uptake of vaccination, especially the adult vaccination, was very, very challenging. And therefore, currently, whether the trial has to continue, whether we should go forward or not, currently the BCG revaccination has stopped. Instead, sir, the randomized control trial results, we do not have that. So what we have devised right now is a case control kind of study design, which we will be rolling out. The protocol has been rolled out, and from January onwards, we will be in these districts which receive the intervention. We will be checking individuals who develop TB disease and matched controls to find out what is the difference in the immunization rates and see whether BCG is providing any kind of protection. So this is a case control study, but the larger randomized control trial that we tried at that has, I shouldn't be saying failure, but from the results, it appears that is going to be it's not going to give any meaningful results. So we wanted to give BCG vaccination to all the adults, the high-risk groups, and compare the reduction in notification in these 280 districts vis-a-vis the 280 control districts. But because the coverage of the intervention is so poor that we are not seeing any kind of difference. Okay, and therefore we have gone to the level of doing some kind of a case control study in order to identify the vaccine protection. So that's the level. So the attempt is being made, but we do not have conclusive results about the value of the revaccination program. So that is one. And secondly, I think age-related factors. What exactly is driving that to be higher? That is something. Reduction in immunity level is one obvious explanation, but we do not exactly know what is driving the higher TB burden among the elderly population.
Thanks, Richard. That was a really great talk on the recovery trial. And for a lot of us, it's been the poster boy for how to conduct quick, relevant studies at a time when it's very difficult to do so. Amongst all the learnings that you very eloquently mentioned, to me, some of the key learnings were to keep it simple, and keep it simple both from an implementation of the trial point of view, as well as the data collection point of view. Every time we embark on a large, ambitious randomized trial, most researchers fall into the trap of collecting tons of data, 90% of which will never get utilized. And I think that was key for the scale at which you were able to shift things. And I think you didn't emphasize the basic structure that you had of having a large network of centers which were ready to take on studies at a very short notice, and the importance of having a platform trial design, which even though we realize the importance and the benefits of a MAMS design, still the large majority of trials in clinical practice today don't adopt that kind of a design, and we are more straitjacketed into the conventional 2-arm or a 3-arm study with very little flexibility and adaptability. I just wonder what we should do both as researchers and as regulators and ethics committees to embrace these pragmatic kind of trials far more readily than what we are doing today. Because even after the lessons from recovery, I don't think we've learned much as far as trial design goes.
Thank you. I think that's a fair point in that trials now are, it's almost gone back to business as usual, and the lessons that we learn aren't being applied very much. I think it's challenging for regulators and ethics committees to have much impact on the level of data collection, because I think they might see that as interfering with the scientific aims of the trial. But I think you're right, as investigators, it really falls to us to think very hard about all of those data points we need. Do we really need them? It sounds strange to be saying don't collect so much data, but actually in trials it can be a real strength. I think the quote is attributable to Richard Peto, which says if you were to collect 10 times less information on 10 times more people, you'd have a trial which was 100 times more informative. And I think that's true, that sometimes the desire to collect too much data really hampers the primary aim of the trial, which is answering the question. In terms of whether we should be doing more platform trials, we probably should be using them a bit more, but I don't think they're a panacea. I don't think every trial should be a platform trial now. There's still very much a place for the traditional trial design, particularly in new drug development. But in common conditions where you've got a number of treatments that you want to assess, there are definitely advantages to them. Thank you.
This is not related to the trial, but what is the impression and what's the general feeling in your country about COVID vaccines? Because it's gone into a lot of controversial, especially after people like Djokovic refused to get themselves vaccinated. I mean, a lot of other public figures have also spoken about it. So,
I'm not an expert on vaccination, but I think there's a certain amount of vaccination fatigue. Everybody was very keen to have their first dose, maybe their second dose, maybe beyond the many doses since. The government's actually narrowed down the people who are eligible to receive the vaccine quite substantially. So fewer people are eligible for the COVID vaccine than would get the influenza vaccine. So it's really focusing on the highest risk groups, but still uptake not very good. And I think that's the mix of misinformation and disinformation, as you say.
I mean, I think that touches on the sort of adherence question of medicines and things in general, that there's a trust issue that's developing increasingly. But patients and the public are now more willing to look at AI and social media and other sources of information. So I think that might need to be a challenge that all of us will be involved with.
I think that was an excellent talk about platform trials. So I think even in the field of tuberculosis at our institute, we are trying to design platform trials, having multiple intervention arms and one common control arm in order to do it more efficiently and also effectively. When you were conducting this trial, there would be several decisions that you may have to make with respect to adding some new arms, discontinuing certain arms for the trial. So how was it set? Because so many intervention arms that you had, I don't think you started off with all those intervention arms to begin with. So what are the rules that you follow when you say, for example, add on an arm, or when you discontinue an arm when such a massive trial is going on?
Yeah, that's a big question. One thing I didn't talk about very much is that for the second wave, we used quite a lot of factorial randomization. So where we could, we randomized the same person into multiple different comparisons rather than just the single shared control group. So that was good, where we still had anti-inflammatory treatments we were testing alongside antibody-based therapies that we were testing. We could randomize people between an anti-inflammatory treatment or not, and then the same person between an antibody-based treatment or not. So that improved the efficiency of the trial. when we were running the multi-arm bit, you're right, it was agonizing because we knew that every patient that we recruited into, say, the lopinavir comparison was not going to be contributing to one of the other ones. So, for example, when we decided to end the dexamethasone comparison, the rule of thumb that we came up with was that we wanted to have 90% power with a p-value of 0.01 to detect a 20% reduction in mortality. With the death rates we were seeing, that required we needed to have 1,000 deaths in the comparison. And when we achieved that, we said we'll stop recruiting into that comparison. We'll see. And we just had to make that decision blind. We were lucky. We said that. We told our data monitoring committee that's what we were going to do. And they said, fine, but you might want to look at your results today rather than waiting 4 or 5 weeks, because they could see that the implications were quite important. But that was the rule of thumb that we used, was to have those sorts of levels of stringency to make sure that our results were going to be definitive, that we weren't going to stop too early, but nor were we going to leave things running too long because of the natural competition that there is between comparisons in those designs.
So I'd like to thank all the speakers for really excellent talks. We've touched on a number of things. Adherence was mentioned, and there's an adherence session that will be tomorrow. But we have lots of good things still to hear today. So thank you very much for attending, and I'll see you after lunch. The second half of our day with looking at secondary prevention, and so this time we have a break for networking in the middle of the this afternoon. So we have going back to non-communicable diseases, and then we have a methodological session after the networking break. So please be aware that there are people who are in the AI digital part of the meeting who are also both interested in and working on health issues as well. So there are people who are spanning both this. So make sure that you talk to everybody, because there's lots of interesting collaborative opportunities and knowledge sharing. So without further ado, we'll start on session 3, the control of non-communicable diseases. And we have Professor Bhargava, who's going to talk to us, coming here from the Indian Council of Medical Research.
Thank you so much. I hope you've had an excellent lunch. I have been given the title by Soumya to talk on burden of non-communicable diseases. And it's a long title: how to prevent complications, how to get patients, how to keep them there, compliance and behavior change. So my talk will be structured really in 2 parts. First of all, I'll talk about the burden of non-communicable disease in very brief. And I will not talk about cancer because we have 2 excellent experts talking about cancer. Dr. Kannan and Pramesh will talk about that. So I'll just briefly talk about the burden. And then I will give one example where, because this meeting is on secondary prevention and also talking about digital sustainability. So I will be talking about one example wherein we have used digital software and programs for controlling one of the major risk factors for coronary artery disease, that is hypertension, in 5 million patients over 7 years. And I think taking a cue from what was in the recovery, we have kept that protocol very simple, and that was the key to being able to achieve that. So these are my current affiliations, and I am no more with ICMR. I have now a small portfolio, and I work at my own and free will. So that's how we stand. Now, South Asia, diabetes and coronary artery disease capital of the world. So the death rate is higher in South Asians, 282 deaths per 100,000 compared to the global rate of 233 per 100,000. This is well established, and this is published, and I think it is higher in Indians. I think Srinath had shown this slide in the morning about how there has been a shift from communicable diseases to non-communicable diseases. And here you can look at what happened in 1990 and what has happened in 2016. And little blue there at the top left, bottom left, which is Kerala, which had already had that epidemiological transition in 1990, and they were ahead as we speak, or you could say they probably got the epidemic earlier than us. Now, this is where we stand. Coronary artery disease is number 1, chronic respiratory disease number 4, neoplasms and cancers are number 5, and then the mental disease, diabetes and CKD, having gone from left to right from 1990 to 2019. And coming to diabetes, now we have this is the INDIAB studies, which is the largest database collected prospectively from different states from 2007, 2008, and still being collected. And we have overall prevalence of diabetes is 11.4%. And that makes a total of 101 million people who have diabetes. And it is definitely higher in urban, and in the rural, it is between 0 to 5%, mostly or slightly higher in southern India. That's where we stand as far as diabetes is concerned. Hypertension, prevalence is 35, and we have total burden of about 315 million people of hypertension. Now here you have to remember the size of India, 3,000 miles north to south and 3,000 miles east to west. So it's a large country to put things in perspective. And again, urban is more, but rural is catching up very high. There are certain pockets where it is hypertension is about 50% in urban areas, and in rural areas it's ranging between 25 to 30%. So it is catching up in a big way. Tobacco use, an important one, and I think tobacco use has fallen slightly, but smokeless tobacco, and I think Pramesh and others will talk about it when they talk about cancers. Smokeless tobacco still remains a problem, and 70% of the smokeless tobacco use in the world is from India, and 90% of smokeless tobacco use is from India, Pakistan, and Bangladesh. And whilst I was at ICMR, we were able to pass a legislation in 2019 to not allow electronic nicotine cigarettes to enter this country. So that legislation has worked. And now Western countries are grappling with the problem of vaping. And so that we were able to avoid with a single stroke of one parliamentary order that was passed. Dyslipidemia, low HDL is the common dyslipidemia. We have not that much high LDL is not that a huge problem, as was mentioned. ApoB and ApoLD and LDL being a major problem in Southeast Asians. So what causes most death and disability? And after COVID, which was there as number 1 at one point in time, it's ischemic heart disease or coronary artery disease. And coronary artery disease remains the most important cause of death and disability. And most important cause for coronary artery disease is hypertension or raised blood pressure. Air pollution is there, elevated LDL, tobacco use, high blood sugar, high body mass index, and low physical activity. So this is where we stand, and the number of deaths is reported here. So Coming to blood pressure, which is the focus of this talk, and benefits of treatment of blood pressure, a 10 millimeter reduction in systolic blood pressure or 5 millimeter reduction in diastolic blood pressure reduces prevents one event of CHD, stroke, and heart failure, and we need to treat, and NMT is 40 for that. Now, we know the rule of halves for non-communicable diseases. That is relevant for diabetes, relevant for hypertension, and other non-communicable diseases as well. That about 50% of NCD patients are diagnosed. Out of those 50% receive treatment, and out of that 50% are under control, and out of them 50% receive the desired outcomes and remain in treatment. And this is the Indian hypertension cascade, which was before we started the Indian Hypertension Control Initiative, which was started in 2018. And if there were 100 patients, 28 were diagnosed, 14 were treated, and 12 were controlled. So this is the India Hypertension Control Initiative, which was basically reduction of cardiovascular diseases by improving the control of high blood pressure among adults in India. This was a project which was initiated at that time. The paperwork was done by Soumya when she was at ICMR before me. And then in 2017 and 2018, I took over, and then we launched this program in 26 districts over 5 states. India has 730 districts. And now we have scaled it up to 156 districts across 26 states, and to strengthen hypertension control treatment. And there are partners, which was Ministry of Health, the WHO India, Indian Council of Medical Research, and the Vital Strategies, which was our technical partners. So how did we control hypertension? 5 core strategies. The 5 core strategies, and number 1 was standard protocol. And this protocol was made very simple, linear protocol, and after tremendous amount of deliberation. And coming back to Abraham Lincoln's statement when he said that if I have to cut a tree, I spend 90% of my time sharpening the axe. So we had several protocol meetings and came on to a very simple protocol where we had state level NCD officials, we had specialists, we had physicians from district hospitals, primary healthcare centers, and representatives for medicine, public health, and we got a linear protocol with just 3 drugs actually, but mostly 2 were used. Amlodipine and telmisartan, just 2 drugs. So very simple linear protocol. Amlodipine 5 milligram, in 30 days, no control, increase it to 10. Add telmisartan if 30 days not controlled, 40 milligram. If still high, then add telmisartan, and then chlorthalidone, which was later on. So this was standardized evidence-based protocol, drug and drugs dose specific, reduces clinical variability, most cost efficient and cost effective selection of medicines was done in this protocol between 2017 and 2023. And these are the first 2 states where we started using this protocol at scale, Punjab and Maharashtra. So we had 159,292 patients on amlodipine, and they were followed up, and 281, 2009, so 200,000 or 400,000 patients which were treated, and we achieved about 70 to 70% control of blood pressure during their recent follow-up. That was the last visit, 1 reading that was used for measuring that on a public health perspective. So this was achieved in a very high percentage, which we were also surprised because we had the regular follow-up. In Maharashtra, it was higher, 76% to 81%. And then what were the challenges in implementing these protocols? There was initially treatment inertia. Initially, there was lack of drugs, and the drugs were not available in the program. So we had to ensure that, and that would be the second major part of our core strategy. Multiple pills influence adherence and availability of protocol drugs. So the second part, the first was the standard treatment protocol, amlodipine, telmisartan, and chlorthalidone. Very simple, 3 drugs, no complications. 5 milligrams to 10, 40, 40 to 80, and then add 12.5, 12.5 to 25. And the second pillar was seamless drug supply. That was causes, and what was required for an uninterrupted supply of drugs was inclusion of the protocol drugs in the state essential drug list. So we know that health is the state subject, so we had to get it in the essential drug list of that particular state before, and then based on morbidity and method, patient load using the Indian Hypertension Control Initiative tool. Then the procurement of the drugs was done, storage and distribution, and 2 key indicators were monitored. One was at the district level, availability of drugs at the district level in the number of patient days, and proportion of facilities with less than 30 days drugs in patient days. So that was ensured, and we had an Excel-based forecasting tool which was utilized. And the drugs availability, if you can look at this graph, most of it has become green gradually with time, and this was improved dramatically between 2018 to 2022. If you look at the number of tablets in Telangana, it was about 200 million, no, 20 crores would be more than 200 million tablets of amlodipine and in the financial year 2020-2021. So adequate drug availability at facility level is the key, and minimum 30 days drugs were given to dispense. So they were given 30 days drugs, so that ensured that they did come up for follow-up visit. So first was standard treatment protocol, which was simple and linear. Second was uninterrupted supply of medications and blood pressure monitors. And then it was team-based, patient-centered care, moving it from district hospitals, tertiary care centers to the primary health centers or the health and wellness centers. That was the agenda, and that was gradually achieved. So blood pressure was measured by a standard protocol, which was fairly simple, and standard blood pressure monitors were used across the country. And the Ayushman Bharat program, which was launched in 2018, was utilized because in the Ayushman Bharat, 150 health and wellness centers, 150,000 health and wellness centers have been set up across the country, measuring 12 parameters in their blood and mental and dental health as well. So screening of blood, glucose monitors, drug dispensing, etc. was done at the health and wellness centers. So this was a decentralized program at the health and wellness centers where 3,000 to 5,000 population was catered to at a single health and wellness centers. Document the process of decentralization from district hospital to health and wellness centers, and the outcomes once decentralization is implemented was also documented, and that has been published. So governance and financing was an issue. Human resources, treatment protocols, availability of drugs, blood pressure apparatus, service delivery, and health information systems, and I'll come touch more about the health information. So the patient flow shifted from the district hospital a little bit, from 10% to 9%, from CHCs to the health and wellness centers. So from the health and wellness centers, from 34%, it became 47% in these. So 200,000, 73,000, 355 patients. And the control, because there were a limited number of patients coming to the health and wellness centers, 3,000 to 5,000, we were able to achieve greater controls at the health and wellness centers, which went up to 63% control of blood pressure. And now the program has gone to 157 districts with a population of 232 million, treating 5.1 million hypertensive patients in 26 states with 14,000 health and 285 health and wellness centers which have been utilized. And this is where we talk about the missed visits, which has been falling, and the control rate, which has been gradually rising. So this is in the first part of the protocol when we were Maharashtra and Punjab, when there were 15 states after that where 1 million people were treated, and maximum control was achieved in Maharashtra and Punjab, then Rajasthan, and the lowest was in Bihar and Jharkhand. The BP control by state, as when we were using one reading, which is the last reading. So the one reading is showing higher control, it's at 68%, because that was the last reading that was being used. Once we were using two readings, that was any previous reading, and comparing with that, it was about 52% controlled. So the last was the monitoring system, and the monitoring system, which was the open source information system, and we called it the Simple app. Which was a front-ended app where the patient had to register. And for the front end was used for registering and managing patients and facility progress, and the dashboard was back end, which used to generate program indicators and manage users. So this app was maintaining patient records on health workers' device, treated blood patients to protocol with BP history. Doctors treat patients correctly and make calls to overdue patients. See your facilities progress in controlling hypertension. And this is the app which was clearly there. And this is how we were finding control in blood pressure rising, registrations rising, and missed visits falling. So what were the key lessons from this app? Key lessons were that real-time cohort monitoring can be done for primary care for blood pressure control. Super fast and easy to use with a QR code. Average duration to register a patient was 70 seconds, and average duration to record a follow-up visit was 13 seconds. Real-time and paperless cohort monitoring for quality care. We had an overdue list, and transfer patients by a click was easily possible. This program was awarded a UN award for high impact initiative by the UN General Assembly in 2022, and the Norman Campbell awarded the World Hypertension League and the National E-Governance Gold Award. These are the several publications that we have from this program. So the lessons from this small program was that very simple and standardized treatment protocol, 3-drug linear protocol, successful adoption at primary care level. Number 2, uninterrupted drug supply, reliable drug stocks at facility level, improved the retention of care, and decentralization at Health and Wellness Center for follow-up and prescription refills, improved the blood pressure control, and most importantly, the information system, which was a simple app, which improved the tracking of the patients and monitoring the program. So this is the India Hypertension Control Initiative. These we have the acknowledgements to the ICMR, the WHO, the state government, the CHO health officers, treatment supervisors, the technical partners, and healthcare workers, and most of all the patients. And that's pretty much it. Thank you so much. I presume you will have the questions after the second part?
Yes. Yes, we'll have joint questions at the end. Thank you very much. Yes, it's interesting to see that echoing that message of keeping it simple.
Correct.
Yeah, being in this control program as well as in the designing of the trial. Okay, so our next speaker is Professor Sarah Lewington, who is here from Oxford. And you've got your slides. Sorry.
Great. Thanks very much. Okay, well, thanks very much, everybody. I think, apologies that I think I read the spec properly, so I'm not really talking about secondary prevention, but it does follow on from the conversation earlier about BMI and basically how good is that as a measure of adiposity. So I'm just going to do a bit of a whistle-stop tour of some studies that I've been involved in globally, but trying to focus on one that I'm now working on in India on obesity, but particularly looking beyond BMI. So just as a reminder as to why this is important, that there's about 56 million deaths a year, of which 28 million before the age of 70, 20 million of those are in middle age, and of those 18 million are due to the non-communicable diseases, with cardiovascular disease and cancer dominating there. But these must be preventable. We've seen dramatic fall in, I don't know whether that's working, dramatic fall in cardiovascular mortality in the UK. So this is at ages 35 to 74, from a peak in the 1960s down to about 2010. But then you can see that it certainly it begins to plateau, and this is just in contrast. I don't want I was using the pointer. No, I wasn't. I didn't want to do that. Thank you. Reducing dramatically compared to cancer, and of course infectious diseases, apart from the blip in infectious diseases in 2020. And then here, just focusing in on CHD and stroke mortality on the left-hand side, again from 1950 to 2010. But again, I commented on that change from 2020, but that sort of change in the pattern, the remarkable decrease really stalling around 2010. And so on the right-hand side, just blowing up from 2000 to 2020, you can see that it really did slow down from 2010 and a slightly worrying trend from 2020 onwards in coronary heart disease mortality. So that's the UK. Well, what about India? Well, this is data from Prabhat Jha's Million Death Study showing the difference in urban and rural India. So again, just going back to that 2000, the age range has changed slightly now. So this is 30 to 69. But in 2000, the CHD mortality rates were similar in the UK and in rural India, but were about sort of almost twice as high in urban India. But go on 15 years, and then the rates in the UK have come down tremendously. So in 2015, the CHD mortality rates are now similar in urban and rural India, and both of them are about higher than in the UK. So why would this be? Why would in a country, it can't be driven by obesity, but obesity as measured by BMI, because the BMI is considerably higher in the UK than India. So I'm kind of setting myself up for saying I think there's a need for a large biobank based prospective study in India. That's if I don't get that far, that's the conclusion. So the major modifiable causes of vascular disease that we know from high income countries, the tobacco, blood pressure, blood lipids, adiposity, and diabetes. And I'm just going to focus on adiposity today, but we know from the evidence that there are some important differences between populations. And in particular, this is work by Emanuele in the Global BMI Mortality Collaboration, just looking at BMI, and this is versus all-cause mortality, and divided those up into the high-income countries where we saw, I think, what was largely known, but that 10 units of BMI approximately doubles the risk of all-cause mortality. That was in the high-income countries. But in the studies in South Asia, much less data, so 176,000 participants in 3 studies. But there's really, well, you could persuade yourself that here, if you want to persuade yourself that it's similar in South Asia as it is in the high-income countries, you could do so. But really, in that area where we've got a lot of data, there was really no evidence from those South Asian countries of any association between BMI and all-cause mortality, which was not, I don't think, the expected finding, but maybe Emanuele will correct me on that later. So we were collaborating with Dr. Gajalakshmi from Chennai, who had a prospective study of 500,000 adults that she'd recruited around the the turn of the century. So this was done foot leather epidemiology, so house-to-house surveys. Deaths were found by visiting the households and then linking to the death registry. And then the cause of death from the verbal autopsies. And so we looked at the associations of BMI with cardiac mortality in the Chennai study. So just as a reminder, this is the global BMI in the high-income countries, but our findings in Chennai are absolutely matched those from the global BMI. So absolutely little or no association, I would say really no association between BMI and cardiac mortality in this study. And that's despite BMI was associated with blood pressure at baseline, BMI was associated with diabetes at baseline, and both of those were associated with cardiac mortality. And we did those analyses as much to persuade ourselves that this wasn't a data issue. Clearly it's not. So there's something very different, whatever BMI is measuring. And so we were very careful, and so not to say that we don't think obesity matters or that adiposity matters in India, but rather that BMI isn't picking up whatever that important aspect of adiposity is. And so I think the conclusion from that is that we need these large blood-based biobank studies with long-term follow-up and for cause-specific mortality in many diverse populations. And so just developing them in understudied populations, where possible using the electronic health records and active validation to improve outcome ascertainment. And then how can we streamline ascertainment of cause of death in the low resource settings? I mean, you've heard from Richard how relatively easy it is to do in the UK, far more difficult where you don't have national electronic health records. And for that reason, I think most of the large studies to date with long-term follow-up and stored blood have been largely done in the high-income countries. So one exception to that is the China Kadoorie Biobanks. That's of 500,000 adults in 10 diverse areas of China. And also this study did resurveys. It's so far done 3 resurveys, aiming for about every 5 years in 25,000 participants to do the whole survey again, so that you have some idea of what those baseline measurements really mean, but also to do some enhancements along the way. But the really striking thing about China is that they have linked to the mortality registers and the health insurance data. And so now have data, and this is probably out of date already, but on 45,000 deaths, 1.5 million hospitalizations. So in total, about 1,500 diseases. It was supported by more than 90 bespoke IT systems. And this is a quote from one of the PIs, Zhenming Chen, called it a long and bumpy journey since the 1990s. So it looks like a really smooth study when you look at it, but boy, was there a lot of work went into that. But really, it's so important that we have data from different parts of the world. So in China, where there's high stroke rates and where most of the strokes get an MRI, a CT scan, you can really tell reliably the difference between the ischemic and the hemorrhagic strokes. And so when they looked at BMI versus ischemic stroke, you see this nice straight line relationship. It sort of fits roughly with what you would have expected from the association of BMI and systolic blood pressure, so largely driven by systolic blood pressure. And so given that, you would have expected the association to be even stronger for hemorrhagic stroke, because the association of blood pressure is even stronger with hemorrhagic stroke. But it was really quite the opposite of that, with only a weak association between BMI and hemorrhagic stroke, which is much less than that threefold difference you would have expected from the effect on systolic blood pressure. Moving west a bit to Malaysia. So this is a study, the PI is Prof. Rahman Jamal from the university in Kuala Lumpur. And this was a study of 120,000 people, kind of similar to UK Biobank, recruited around the same time, roughly the same percentage of female, slightly younger. But we looked there, and one of the striking things there is the 3 different ethnicities. And you can see that sort of by age, the percent obese was much higher in the Indian and the Malay participants than it was among the Chinese participants. And that the prevalence of diabetes was also much higher. Well, it was higher among the Indians than among the Malays, and was higher than among the Chinese. So is this anything to do with adiposity? And again, strikingly, at a given BMI, much higher prevalence of self-reported diabetes among the participants of an Indian origin compared to Malay or Chinese. So sort of almost 30% among those with diabetes among people with a BMI of 25. So we thought, well, one way of looking at this was to do a DEXA sub-study. We've talked about BMI not being adequate. Let's have a look at the fat distribution in those studies. And so we were able to collaborate with them on this sub-study of 5,000. And what we did find was that at a given BMI, there did seem to be about a 5% higher body fat among both the Indian, both men and women, maybe slightly more so among the women, the Indian women. So that was noticeable. And then when we looked, this was just at the cardiovascular risk factors back to BMI, and there's really nothing particularly striking apart from maybe the triglycerides, where there was a much weaker association of BMI with triglycerides among the participants of Indian origin. So, but there are really very few large-scale studies comparing body composition and cardiovascular risk factors and diabetes across ethnicities. And so we moved to India, and we were very lucky to collaborate with Dr. Rajesh Dixit and Sharu Matre in the Tata Memorial Centre for Cancer Epidemiology. And they're running or developing a large prospective study. They're aiming for about 2 million adults aged 30 to 69. They've done a baseline survey. They've completed about 70,000 with physical measurements and a blood sample on about 60,000. They're aiming for mortality and morbidity follow-up with periodic surveys of a sample of participants. And I say we've been really lucky to collaborate with them. We're doing some studies with them. In particular, the one that I'm involved in is another DEXA sub-study, so aiming for 10,000 participants, got data hot off the press on 4,000, but with Richard and our colleague Parminder Judge doing a renal sub-study there, looking into the gut microbiome, a depression sub-study where we're trying to see the 4 screening questions really didn't seem, they were suggesting a very high prevalence of depression in the cohort. And so we're doing proper diagnostic test in about 5,000 of those participants to see how well those screening questions are really picking up. And then the most recent is working with a colleague, Aidan Doherty, doing the wearables. So we're really excited to think how the imaging for the adiposity with the renal and biomarkers and the physical activity are all going to come together in that cohort. So just to give some background to it, young, middle-aged, you see the vast difference in education between the men and the women. Somebody showed before the high use of tobacco, but it's largely chewing tobacco rather than actually smoking tobacco. But I just wanted to focus really for now on the BMI, where there's a low BMI, but see quite a high percentage body fat among the women, but still the self-reported diabetes is surprising, is still very low. And so I just wanted to compare that with the UK Biobank study. For those of you who aren't familiar with it, it's 500,000 adults from around the UK and all followed up through the electronic disease for deaths and hospitalizations. And this is just a comparison between the two. So slightly younger in Isha than in the UK Biobank. You can see that the BMI is higher in the UK Biobank than in the Isha study, and that the self-report of diabetes is considerably higher in the UK Biobank than in the Isha study. And the reason I'm sort of making that comparison was that we then wanted to look at the compare between the men in the Indian study of healthy aging and the Asian men in the UK Biobank. And you can see that there's a lot of overlap, but basically the men in the UK Biobank are heavier, as you saw, by about 3 units compared with the men in Isha. But by contrast, the waist-hip ratios appear to overlap completely. So the distribution of the waist-hip ratios overlap, suggesting a higher waist-hip ratio at a given BMI among the Indian men in Isha compared to the Indian men in the UK Biobank. So again, thinking about that DEXA sub-study, what can we see there? And here it's even more striking. So the black at the bottom is the white European ancestry in UK Biobank. The blue are the South Asian ancestry in UK Biobank, and the red are the data from the Indian study of healthy aging. And I think, as you're alluding to, Riaz, that sort of this is suggesting that people are coming towards the UK as they move. But certainly the higher body fat, despite the fact that the overall BMI is lower at a given BMI, considerably more body fat among the men in India compared to the men in the UK. And that was similar for waist circumference movement, not quite as striking, but similar for waist circumference. But this is just, and these are very new data, these are from the Indian study, that actually we don't see anything particularly striking between, so the top two are the anthropometry, the body mass index and the waist circumference. The bottom three come from the DEXA machine. There's really nothing sort of particularly striking when we just look at these two cardiovascular risk factors. So these are per standard deviation of each. So they've been sort of standardized to be showing the same thing. And really they are, however you measure body fat here, suggests that that has the same effect on blood pressure, at least, but I think it'll be very interesting when we get the blood biomarkers to go with it. So here's just a very preliminary, some very preliminary findings from this renal biomarkers sub-study, suggesting very high levels of potentially of kidney disease, that these cystatin C, 65% of them were above the normal range. A high percentage with HbA1c indicating diabetes. So although the self-reported diabetes was very low, actually it looks like the prevalence is much higher and more like sort of 17% rather than the 3 or 4% that we saw. But the real value of this study is going to come from the long-term follow-up for deaths and major diseases, and that's probably the greatest challenge going forward as to how you can follow people up long-term without a national ID or the like in the NHS number like we have in the UK. So what are the opportunities and challenges over the next few years? Well, I think the real challenge is developing a scalable approach to the outcome identification and adjudication. But if we achieve that, then that's like the real opportunity here with the linkage to health. If we can link to health-related data sets. The cohort has already expanded into Goa, so aiming for 100,000, using the same systems, the same questionnaire and systems in Goa. A 10,000 pilot is ongoing, but particularly keen to build collaborations. The team in Tata Memorial Centre very keen to build collaborations, and of course the usual challenge that we all face of obtaining sustained funding. So I kind of hope I persuaded you in that whistle-stop tour of the need for big and simple but long-term prospective studies, blood-based prospective studies in many populations, because we really need that country-specific evidence on those big modifiable causes, and to monitor the different and changing effects in many populations. So that just leaves me to sort of particularly thank the collaborators at the Centre for Cancer Epidemiology, without whom none of this would have been possible. Thank you.
Thank you very much indeed. So now we have plenty of time for discussion, and we can ask questions of both of our speakers.
Thanks. Thank you both for fantastic talks. I guess one question for you, Dr. Ram, is we've talked a little bit about polypills in discussions outside and inside. What about just combination pills before we jump to multi-medical medicine formulations? What about just combinations of hypertensive agents in order to make your study potentially a bit more adherent? Because we know that Sevicar, for example, includes all three of those. I just wonder, with your cap on, with your industry links and factories, I mean, could you not just do that?
I think there are a few polypills available in India at the moment, but we had a few patients who were controlled on just one drug. In fact, a large number, and only a small dose of amlodipine, 5 milligram. So from that perspective, it may not be, and whether we are there for polypill yet or not, that question still remains. Although the concept was first promoted in 2003, I was reviewing Salim Yusuf's trial when it was funded by the Wellcome Trust and Cadila, the TIPS 2 and TIPS 3, but still we haven't that much evidence yet to put it in the water supply, as was spoken.
Follow-up question. So coronary disease risk in South Asians, we've got data, and we've seen data from around the world that heart disease, for example, starts maybe 10 years, we estimate, earlier than Caucasians. So should there be more aggressive management of risk factors like blood pressure, rather than using the same standard that we use for everyone else around the world, if we are to reduce that health inequality?
I think we have to be definitely more aggressive to manage risk factors in India, and the recommendation now are that the age of 25, you should know your numbers. You should know your weight, you should know your cholesterol, you should know your blood sugar, you should know your blood pressure. So that is important. And with the 150,000 health and wellness centers, this is also going to the rural areas, measuring all these parameters, simple parameters, but ones so that interventions can be started. And I think the most important aspect for coronary artery disease, particularly in the young, in Indians, is when we do an angiogram, we find normal coronary arteries. They normally have a blood clot, which is promoted by tobacco. And chewing tobacco still remains the problem in a third of the population. And tobacco causes coronary constriction, tobacco promotes atherosclerosis, tobacco promotes fibrinogen and clotting. So that is one of the biggest problems which I feel is in India, chewing tobacco. And that is rampant in the rural areas. And we see a lot of patients, and there's enough data on chewing tobacco and coronary artery disease. In fact, we did a very small study on chewing tobacco in patients of stable angina with normal treadmill, with positive treadmill tests, the syndrome X kind of thing. We did their coronary angiogram, and then we gave them chewing tobacco on the table. It was ethically cleared and everything because these were people who were treadmill positive. And then lo and behold, we found coronary constriction clearly demonstrated that occurring because of chewing tobacco. So that I think is an important risk factor still remains. Fortunately, we've not gotten into that vaping business, and that was a legislation which was very successfully passed through the parliament.
You sort of jumped the gun a little bit on my question, but I was about to ask, where does vaping fit in? So does it act like smoking, or does it act more like smokeless tobacco? I mean, I realize it's a vapor, but how do you have a sense of where it fits in that risk profile?
It would act like I would say smokeless tobacco, because there is nicotine, and nicotine is there in chewing. There's no tar, there is no car, none of the in fact, in that study that we did in coronary angiogram, we took plain simple tobacco leaves, simple tobacco leaves from that. So I think smoking is, vaping is, although there have been a lot of people saying that
I think that's been very clear in the UK. We're seeing huge numbers of young people.
I just pick up on that. Sorry, that's me. I've got my own microphone. Just pick up on that on the vaping, because I think the latest data I saw on tobacco vapes, that tobacco use among the under, I don't want to say under 25, so I don't know exactly the age, has absolutely plummeted as vaping has gone up, so that they match now. So it's not that, I don't think that it's adding to tobacco. It's really striking the drop in tobacco use among young people in the UK. So it'll, who knows? I don't think we know yet, because it's going to be, 40 years before that lot have enough disease for us to know whether they're better off or not. But it doesn't seem like they're then taking up tobacco instead. It does seem like they're using it instead of cigarettes at the moment. No, I'm not advocating for thanks. I mean, I think it'll be interesting, because there's the adolescent health study in the UK, so recruiting. We're going to recruit 100,000 adolescents, and I think if they're able to follow them, and that, of course, is going to be the challenge of how you follow people once they're over 18, who still won't be accessing the health service that much, but if they are able to recontact them, it may be 10 years' time, and then see what their social behaviours are. It'll be interesting. We have to find something that teenagers think we don't want them to do. They need to find something to rebel.
So, can I ask you a question? Yeah, to you, Sarah. Thanks. No, very, very nice showing, different relationship, BMI and different disease. Couple of questions. One is so there's been a lot of discussion about different BMI threshold for South Asian, threshold specific. Just to get your thoughts about that. Is it really different threshold, or should you think about a single one as a BMI and think about the BMI threshold for obesity, overweight, and so on? The other one is the different relationship with BMI and CHD in South Asia versus rest of the world. Is it the same for diabetes, or in some of your data you see that there's like similar relationship for the diabetes as an outcome?
So I don't think there was. I'll answer the second one first, if that's okay. The BMI and diabetes. I don't think there were enough diabetes deaths because the Chennai study was mortality. There weren't enough deaths from diabetes. And anyway, those would be sort of acute diabetes. They get mixed up with CHD anyway, don't they? I mean, it was striking that BMI was associated with self-reported diabetes in the Chennai study in a similar way, similar sort of strength of relationship that we've seen in previous studies. So I think it'll be interesting to see when we have more detailed data on beyond BMI with diabetes. I think will be particularly interesting, especially with the higher percent body fat, and potentially when we're able to look when we've got the data in and cleaned it properly on the visceral fat and stuff. I think that will be really interesting, because clearly there is a higher percent body fat. But it was quite striking that it was still, although it was higher at a given BMI, the relationship was actually similar between all those three groups that I showed. So the regression line was about the same between the three. In terms of whether you should have cutoffs, I think the danger with changing the cutoff is that you don't have a comparison of percent obesity if you're defining obesity by BMI, rightly or wrongly. So I think there's a danger of doing that you could, if I want to show that there's more obesity in a country, I'll just lower the BMI cut point that defines obesity. So I think we need more data really on where those, if you're wanting to do it by risk and which disease you're talking about. But I mean, certainly those Chennai data and even your data from the global BMI collaboration didn't suggest that actually people, certainly, that they were at higher risk with a BMI of 25. If anything, it suggested little to no relationship, which I don't think either of us were expecting from it, were we? I mean, that's my thought on the BMI, but I'd be open to others' thoughts. I think we need to know more about what BMI is actually measuring in different populations, really.
I guess just to get both of your thoughts on the question of defining South Asians and Indians, and we're also, it's easy for us all to kind of say Indians, blacks, whites, etc. In India alone, we've got DNA genetic studies that show enormous genetic variability from one side to the other, up and down, right? How do you kind of deal with that when you're trying to do these sort of large epi studies, international comparisons? Like the people in the UK who are Indians, I don't know which part of India, but let's assume they're kind of Gujaratis and Punjabis, etc. You're comparing a slightly different population in India. So I guess all these sort of challenges about, I mean, I guess if you've got biobanks, you could use genetic markers and ancestry kind of definitions, but just really a general thought, because we've always struggled to kind of address that one question. And even if you say India, Pakistan, Bangladesh, I mean, it was all one country at one point. It's just artificial geography that's then divided it. So we shouldn't be using these either.
I think, shall I go first? I mean, I think that's a really valid point, because I was going to say, even more embarrassingly, I've used South Asians in the UK biobank just to get the numbers. So yeah, that is the whole continent, if you like. So very, very broad on. I think one of my plugs for the Indian study of healthy aging will be, if anyone knows of anywhere where they could get some funding to go into the different regions. And sort of in my mind, the data I was showing were from Barshi, so in rural Maharashtra. If they get it in Goa, that's really different. And then if they can do the same, using the same protocol, the same questionnaire, the biobank procedures in different states and parts of India, I think that would be hugely valuable. And then you would have something like the China Kadoorie Biobank, which was never meant to be representative of China, but they did 10 diverse regions of China with different diseases and different exposures deliberately to try and get that heterogeneity and that diversity. I mean, if that could be achieved in India, I think that would be fantastic for the next generation of researchers.
Yes, genetically, India is very, very, very diverse. And as you mentioned, India, Pakistan, Bangladesh, they are all probably similar or dissimilar, whatever you can. But the risk factors still remain the same. The food habits quite similar. The use of fats in the diet, use of carbs in the diet, use of tobacco, less physical activity, they could explain a lot of things rather than the genes per se.
Just in response to your last point about the more diverse population, I'm not sure whether you've collaborated with the International Institute of Population Sciences in Mumbai. They're doing a study very similar to Isha. It's called the LASI study, again, a study of aging in India. 73,000 individuals being followed up over every 5 years, and they are deliberately sampling almost all the states and union territories in India. So they might be a good group to collaborate with.
All right, thank you very much. Welcome back, everybody. So we have our final session, which is more methodological and talking about things. So we have Professor Pramesh to start with, and then previously advertised as Sir Richard Peto, it is going to be Sarah again giving Richard Peto's talk. So, so we'll still have the material that he was going to present, but we'll start with this. So turning to looking at cancer care. So this is a very important topic that we haven't touched on yet. Over to you. Thank you.
Thank you. Continuing the theme of speakers not sticking strictly to the topic that they've been given, I'll, as a surgeon, speak about prevention. And I've divided my talk into these points. I'll start with therapeutics and why that is not enough. A much broader definition of prevention and looking at it with a broader lens. Learning from some success stories, some outside of India, some within India. The role of contextually relevant research. We heard a little bit of that in the morning. The need for a systems approach, and this dichotomy that we often hear between communicable and non-communicable diseases. And finally, I'll end with the concept of equity as a global challenge currently in health. So we've had remarkable advances made in cancer treatment over the years, whether it be robotic surgery, proton therapy, personalized medicine, checkpoint inhibitors, immunotherapy, and the newest kid on the block, which is CAR T cell therapy. And these have truly revolutionized the way we treat cancer. And there are plenty of studies which show that previously diseases which were thought of incurable have actually come up with very good outcomes, some lasting beyond 10 years. And these are some examples in chronic myeloid leukemia, in ALK translocated lung cancer, metastatic melanoma, which used to have a median survival of about 6 months. We're now talking in 10-year survivals in a previously untreatable disease. This is non-small cell lung cancer, dramatic improvements that we've seen with newer therapies. So when we have all of these, and I'll just try and use these to kind of wake you up from the afternoon's session. Usually when you have a quiz, someone asks you questions and you're supposed to give the answers. I'm going to flip this around. I'm going to give you the answers and ask you to guess the questions. And I promise you it gets easier as it goes. So I'll start with the first one. 66.5 is the percentage of all bankruptcies in the US due to healthcare costs. 9 million is the total borrowing by US citizens in 2019 purely for healthcare costs in US dollars. And anyone wants to start guessing what 17 is? It's the percentage of adults with healthcare debt who will either become bankrupt or lose their homes in the US every single year. I told you it's going to get easier. Now I want you to start guessing about what these numbers are. 40? Anyone? Correct. See, I told you you'll get there. It's the percentage of patients in India who borrow or money or sell assets for cancer treatment. 5.5 million people in India pushed below the poverty line due to healthcare costs. This is not limited only to cancer, it's all healthcare costs. And 63 is the percentage of healthcare expenses in India which are met from out of pocket. Very different system from what the NHS operates in. And this is not limited to India. These are cancer costs in the US over the 50-year period. And as you can see, there's been a steady increase in the monthly costs of cancer care over the years. And in case you thought this is okay, adjusted for inflation, the y-axis is actually in the logarithmic scale. So what used to cost about $100 a month now costs $10,000 a month, so roughly 100 times more than what it used to be. And when we look at the median improvements in survival that all of these new therapeutics have got, these are unselected 72 consecutive drugs approved by the US FDA. What you see on the graph above is a median improvement in progression-free survival in cancer of 2.2 months and a median overall survival improvement of just 2 months. So we're spending $10,000 a month for a 2-month median improvement in overall survival. So this also brings us to the point of access, and I'll use this heat map that we created of 75,000 patients who visited us at the Tata Memorial Hospital. What we did was geotag them based on their residence, location of residence. And as you can see, this dense population that you see in and around the black dot where Tata Memorial Hospital is located is fairly understandable. That constitutes just 27% of patients who visit us. 73% of patients come from outside the state of Maharashtra. And again, just to give you context, if you were to travel from the northeastern tip of India to Mumbai, it could take you anywhere from 12 to 16 hours, even if you took flights, thanks to difficult flight schedules. And added to this was the expenses of living in a city like Mumbai, which meant that a large number of patients actually ended up not completing their treatment. And this is similar. These are several states in India. This is the state of Uttar Pradesh, where we looked at the heat map of where facilities were available. And as you can see, there are vast areas in green which did not have access to cancer facilities. This is again the state of Bihar and Jharkhand, similarly demonstrating that patients still, even within their own states, have to travel hundreds of kilometers, and this is similar in the state of Assam as well. Added to this is the fact that the projected cancer burden in India is likely to go up almost by 60%, both by way of incidence as well as mortality in just 2 decades. And this is an Ernst & Young report which looked at the current cancer care facilities, which is the first graph is the number of comprehensive cancer centers. The bars in green are what is required as a bare minimum today, not accounting for the projected increase. And the bars in blue are what we actually have today. And what you notice is that we need anywhere from a 1.4 time to a 2.6 time increase in current infrastructure and human resources, even to meet today's requirements, not to speak of the projected requirement in 2040. So clearly, just trying to treat your way out of disease is not an approach that we can take, and therefore it becomes very important that we reduce the burden of disease rather than just try and treat patients that we see. And just to bring us back to what prevention is all about, the WHO definition is great, but it doesn't capture the entire spectrum of what prevention is all about. And I find that though we understand the value of prevention and how every dollar or pound or rupee spent on prevention is worth many times over by way of economic returns, I don't think we've prioritized it enough by way of healthcare expenditure. And India, like many other countries across the world, do not spend enough on preventive healthcare as it does on therapeutic healthcare. So the life course approach, which looks at prevention right from birth and sometimes even at a prenatal period, going right up to retirement and subsequent death, is something that has been embraced across, and the requirements keep changing as this time progresses. And I like to think of prevention much more broadly in these terms. Primordial and primary, which is what we typically associate prevention to be, public health measures like making clean air, greener environment, immunization, and so on. But going on to secondary prevention, which is early detection and screening, but much further down to tertiary and quaternary prevention as well, which is reducing disabilities and complications, and finally to reduce harms caused by medical intervention. So this gives a much broader idea of prevention than what it otherwise would. And there are various interventions which look, depending on which area of disease you're looking at, and practically every disease has some part of it which is preventable, except probably the genetic diseases that we need to deal with. And while it seems like quite intuitive, it's sobering to think that this set of 9 voluntary global NCD targets that the WHO set out as part of the SDGs, even with an extended target of 2030, is something that very few parts of the world are actually coming anywhere close to achieving. So clearly, primordial or primary prevention is incredibly difficult. And much as we might like people to stop smoking when we ask them to lead healthier lifestyles, go out and exercise, what we realize is that even we don't do it. I don't think I did my exercise today before I came in for this meeting. So it's something that's easier said than done. But and especially when it comes from moving from pilots, there are no deficit of examples when it comes to pilots being run. But when it comes to scaling it up on a population level, especially in a country as large as India, the valley of death has been fairly steep. But there are some successes, some of them fairly resounding successes, which I think we should learn from. And I can't think of a better example of this than how the world dealt with the global HIV/AIDS epidemic. And when you look at what happened in the 90s, this kind of peaked because nobody knew how to reduce this burden, though everyone was aware of the etiology. And I think it's one of the remarkable successes of medical science today that we've pretty much converted what used to be a uniformly fatal disease to something that you live with, and you live with very well. And I think the supporter of this particular meeting has a lot to do with the fact that he was able to, through his company, supply antiretroviral drugs to Africa at a fraction of the cost that it used to cost otherwise. But it was not just the drugs, it was safe sex practices, damage limitation as far as sexual practices were concerned, and a whole lot of interventions that actually helped us achieve this progress in HIV/AIDS. You heard this morning again about a similar example in tuberculosis, again, something which is a global problem, at least in this part of the world. But again, remarkably, with a series of interventions, we've been able to reduce the overall burden in several parts. So there are some success stories from India as well. I think
the way we handled COVID-19, especially after the vaccine, especially with the vaccine rollout, was remarkably efficient. There was one single day where we had 4.3 million vaccination doses being administered. And the way we use technology to ensure that every person who required the vaccine actually had access to it and did so in a remarkably short time has been an excellent story to try to replicate. HPV vaccination has been a more difficult problem to solve thanks to the fact that there was widespread panic with COVID-19. There was very little hesitancy both amongst the public as well as the government to roll out COVID-19. However, HPV has been a different story altogether. But nevertheless, this small state in Northeast India achieved 98% coverage of girls for HPV vaccination and has been truly an exemplar state for other states to emulate. Coming to tobacco, Chandigarh took the lead in creating a smoke-free city. And this was again thanks to the fact that in spite of heavy opposition from the tobacco industry, there was a lot of public mobilization that happened, advocacy which happened at a government level, which enabled this city to become smoke-free. And it's in large parts today, even now remains fairly smoke-free, at least in public areas. These are some of the more recent preventive and health promotive actions that the Indian government has taken. Eat Right is from the Food and Food Safety Society, where looking at healthier ways of eating and making sure that there are warnings about the harmful effects of certain ultra-processed foods being quite widely disseminated. Another initiative from the Government of India is Fit India, which encourages corporates as well as organizations in the government sector to embark on fitter, healthier lifestyles. So I think something that we've not spoken about as much has been the role of contextually relevant research. And I'll use a therapy example to illustrate why we need research that is relevant to the needs of the region. So we looked at close to 700 consecutive randomized trials, which were published in high impact journals, all related to cancer. And the graph on the left shows you on the left column, the actual cancer burden measured by way of mortality rates globally. And on the right, the prioritization as far as randomized trials in cancer were concerned. And as you can see, there's very little correlation between the actual burden of disease versus the number of randomized trials that were done to address this problem. And we also looked at what the distribution of these randomized trials were. This was 700 randomized trials. 92% of them were led out of high-income countries, which meant that either the first author or the corresponding author or the senior author hailed from a high-income country or was funded by a high-income country. 8% coming from low, upper, and middle-income countries. 87% of them in cancer tested systemic therapies, which meant that between surgery, radiation, survivorship, palliative care, only 13% of randomized trials tested any of these. However, when we separately looked at the 8% led out of LMICs, these trials were less likely to be funded by industry. They more likely met the primary endpoint. When they had a positive effect, they had a larger effect size, and unfortunately were published in a lower impact factor journal, regardless of whether it was positive or negative. Now we can spend the rest of the afternoons deciding on whether impact factor is a good surrogate, but nevertheless, this is what we found. So we got a bunch of people together to brainstorm on what should be the priorities for cancer research in low and middle income countries, but looking at it from a global perspective. And we had leaders in cancer control from the WHO, the National Cancer Institute, and several other global oncological societies to be part of this. And we came out with these 5 key priorities for research. The first, and many of these are relevant to the theme that we are discussing now, which is prevention. The first was to reduce the burden of patients presenting with advanced disease. In most low middle income countries, over 2/3 of patients present with advanced stages of disease. To improve access, affordability, and outcomes in cancer care via solution-oriented research, health economic evaluation and health technology assessments, quality improvement and implementation research, and to leverage technology to improve cancer control supported by robust evidence. I just went through these 5 primarily to illustrate the fact that most of the 700 randomized trials that we looked at did not prioritize any of these areas, which global experts agreed upon were key priorities for low and middle income countries. So as a consequence of this effort, we actually went ahead and funded several trials through the National Cancer Grid. And the ones which I've marked with an asterisk has some element of prevention which are associated with this. And what we've realized is that we're able to get very large randomized trials ongoing in a low middle income country, looking at unmet research areas like repurposed drugs, with standardization of treatment, with using well-known drugs like aspirin, the role of radiotherapy and surgery, none of which are actually prioritized by industry when it comes to funding trials. And all of them done at a fraction of a cost of what it would take in a high-income country. So a couple of examples that we did at the Tata Memorial on screening. This was a study which looked at visual inspection with acetic acid as a screening method for cervical cancer. This was a cluster randomized trial. 150,000 women in 20 clusters randomized to either screening or no screening, which is the standard treatment of standard screening method in India at that time. There was no overdiagnosis that was observed as at the end of the trial. This was again published in the JNCI. What we were able to show was a 30% reduction in cervical cancer mortality with a very low-tech intervention which could be administered by trained healthcare workers. And as a consequence of this study, the Ministry of Health started mass screening for cervical cancer in 100 districts, which is subsequently likely to be scaled up to all districts. It has run into some hurdles, but nevertheless, that's the primary aim. And as a part of the implementation part of it, we've been training health workers and train the trainers program using a blended learning module. The counter study to this, or this was actually as part of the same cluster randomized trial, which was for screening by clinical breast examination on breast cancer incidence and mortality with a follow-up of 20 years. And we were able to show a 15% breast cancer mortality reduction in the overall cohort and a 30% breast cancer mortality in women over the age of 50 years, again using a very low-tech technology, which is just clinical breast examination by trained health workers, because access to mammography and trained radiologists who could interpret the mammogram was a challenge when it started. So all of this brings me back to the need for a systems approach. And I'll use a cancer example, but this is equally relevant to other areas like, as we discussed, HIV or tuberculosis as well. One of the success stories in lung cancer has been the reduced mortality rates. And as you can see, what started off as pretty much of an epidemic proportion, once we started getting information about the effects of tobacco smoke and legislation that was brought in, taxation increasing, brought about a substantial risk reduction between 1970s to about 2000. But subsequent to that, the drop, though it has been continuing to reduce, has not been as substantial as it has been. And a lot of the reasons why we haven't made as much progress in the last few years, in spite of dramatic improvements in therapeutics, is the fact that we've not addressed the fact that there is a lot of stigma still associated with lung cancer. The approach that's taken with lung cancer is that people smoked, so they got lung cancer, so they deserve it, and probably there's the stigma that prevents early detection of lung cancer. We know that we are dealing with an extremely powerful industry that is capable of influencing politicians, regardless of which part of the world you are in. The challenges, though we have now good evidence to support lung cancer screening using low-dose CT, the challenges that we've had with doing this on a population level, even in high-income countries, and the lack of ready access to therapeutics and to high-quality healthcare facilities. So when we look at addressing the problem of lung cancer, we need to look at it as how do we overcome the issues with the tobacco industry? How do we get tobacco to be consumed less than what it used to be? How do we get screening methods in a way that it is accessible to individuals who are at high risk for developing the disease? How do we get molecular diagnostics, which have now transformed the treatment of lung cancer? How do we get the effective drugs out to them at a cost that is affordable by patients? And finally, looking at this new evidence that links climate change to lung cancer, and clearly looking at either of any of these solutions in isolation is not likely to be of benefit, and therefore we need a systems way of thinking that looks at addressing all of these issues and not just one part of the overall problem that we are facing. And I think this summarizes the approach to people-centered NCD prevention very well. There are some general principles. It cannot happen just with involving preventive aspects to it, but by also enhancing service delivery, because we're not going to completely end disease as it stands. And overall, a systems strengthening, which is looking at strengthening the overall health systems to make sure that we're able to address this problem. I'll come now to what I call the false dichotomy between infections and NCDs. And we've heard this over and over again about the epidemiological transition since morning. And a number of people use this graph as a reason for why we should focus on NCDs in low middle income countries. Clearly, it is known that there has been a reduction in infectious disease and a corresponding increase in NCDs. And this is across the world, regardless of whether you're in a high income country or a low middle income country. But we also need to know that the transition has not been exactly very linear, and there have been ups and downs in the way it's done. And all of us need to just remember what happened 5 years back, that it just takes one pandemic to completely shift what we call this epidemiological transition. So with the result that in 2021, the maximum number of deaths actually happened because of COVID-19 and not because of NCDs. So we're just one pandemic away from this so-called epidemiological transition, and therefore I call this a false dichotomy between the two. And why does this dichotomy hurt us? The problem is that it creates artificial and competing priorities. And I'll illustrate that by an example of why I feel that is so. The truth is that most of these solutions look at addressing three different areas. It addresses root causes. When you treat infectious disease, it also makes sure that you look at poverty alleviation as one of the solutions. We look at better sanitation, and these have an effect on NCDs as well. It prevents long-term complications, and I use hepatitis B as a classic example of this. It's not just preventing hepatitis, it's actually preventing hepatocellular carcinoma, and we have other examples of how immunization reduces the incidence of NCDs. And finally, it improves overall public health. An isolated intervention looking at infectious disease looks much beyond infections and goes on to other aspects of public health as well. And finally, how do we classify climate change? Does it relate to infections? Does it relate to NCDs? It's all over the place, right? I mean, so I truly think that this dichotomizing is causing us more harm than good. I'll end with something that's very close to my heart, which is on equity in health. And I think today, in today's world, where we are seeing increasing polarization by governments, it has become a global imperative that each of us starts thinking of equity, not just as a luxury, but as a necessity that each of us should work towards. And I'll demonstrate that with a paradox. We've never lived at a time as good as it is today. And this is regardless of what you might have experienced over the years. And I'll show you why I feel this is true. If you look at extreme poverty, regardless of which part of the world you live in, there have been dramatic reductions in what we define as extreme poverty. Food supply adequacy is improving again, regardless of which part of the world you live in. Sanitation levels, this is the number of people who are exposed to unsafe sanitation, is reducing everywhere. Education, the average years of education has been improving over the years and dramatically over the last couple of decades. Global literacy, again, going up very high. Human Development Index, regardless of which part of the world you are in, improving over the last 200 years. GDP per capita, again, increasing regardless of which part of the world that you live in. So I said there's a paradox. The world has never been a better time to live in, but the world has never been more unequal than it has been today. And I'll use a couple of examples to demonstrate that. This is data from the World Inequality Report, and the bar on the left shows annual income. The top 10% of the world's population accounts for over half of the world's income, and the bottom 50% of the world's population accounts for less than 10% of the world's income. And I'll point you out to something which is called the T10B50 ratio, which is the ratio of income of the top 10 to the bottom 50. And if we were to divide 52 by 8.5, it comes to 61%. Just hold on to that number, 61%. When you look at overall wealth, the inequity becomes even more stark. The top 10% of the world's rich account for over 3/4 of the world's wealth. And the bottom 50% of the world's of the world accounts for less than 2% of the world's wealth. So clearly, this is not something that's sustainable. And strangely enough, these inequities exist regardless of whether you are in high income countries, and sometimes these inequities are even more pronounced in low and middle income countries as compared to high income countries. So this is a graph which shows the overall levels of global income equality. And while things worsened a lot from 1820 till about 1980, we made substantial progress going from the T10-B50 ratio being 53x in 1980 to 38x in 2020. All it took was a pandemic to go up from 38x to 61x. So the gains that we made from 1980 to 2020, over 40 years, were wiped off by one pandemic. This is gender parity and salaries that women make as opposed to what men make. And while there has been some progress compared to what it was in 1990, we'll all agree that it's a far cry from what it needs to be. And again, depending on which part of the world you are in, high income countries actually have lower gender parity discrepancy as compared to countries in Asia and the MENA region, again demonstrating that gender equality is not something that we can take for granted. Now, how do all of these inequities impact health and healthcare? This is not turning out to be a health economics talk. We need to link it somewhere to health and healthcare. If you look at healthcare expenditure versus GDP per capita, there's almost a linear increase. As the country's GDP improves, the country spends more on healthcare expenditure. But does increased healthcare expenditure automatically mean healthier outcomes? It seems it does. When you look at disease burden as marked against health spending per capita, you again see linear distribution. You actually see the more you spend on healthcare, the better your disease burden is, or the less the disease burden is. And I think the COVID-19 vaccination coverage earlier on in the pandemic demonstrated that very clearly. Vast swathes of Africa not getting access to something that was life-saving and which was in surplus in high-income countries like the US. I'll use this example again to demonstrate the impact of economic inequity on healthcare inequity. What you see with the top graph is the overall number of cancer deaths. That's the absolute number of cancer deaths that's going up, and that's understandable. The second one in the middle is cancer death rate, but adjusted for population, but not adjusted for age. But when you adjust for population as well as adjust for age, you actually see almost a 1% reduction in cancer mortality every year, which is remarkable. I think given the burden that we have, a 1% reduction is remarkable every year. But this doesn't tell us the whole story. And given the fact that the predicted number of global cancer diagnosis is likely to go up disproportionately higher in less developed countries as compared to more developed countries, this becomes very relevant. So this is on the left, the overall reduction in cardiovascular mortality. It's come down by 53%. In contrast, the cancer mortality has come down by only 17%. But nevertheless, 17% reduction in mortality is substantial. But that is limited to countries with a very high human development index. If you go to the medium to high human development index, which is not even scraping the bottom of the barrel, you find that the 53% reduction in cardiovascular mortality drops to just 19% reduction in the same time period. And the 17% reduction in cancer mortality drops down to just 5% reduction in cancer mortality in medium to high human development index. So clearly, there is a linkage between health and equity. So in summary, I think we clearly demonstrated we can't treat our way to health. We need prevention as an integral part of our overall strategy. But prevention, the way we conventionally associate it with primary and primordial prevention, is incredibly tough. It's easy to pilot, but difficult to scale. And a systems approach to health is critical, and I don't think we can approach it in a siloed manner, looking at addressing only some of the problems that we face. Strongly believe that infections versus NCDs is a false dichotomy which distracts us from our overall healthcare strategy. And while tremendous progress has been made in health, ensuring equity at a global scale is an ethical responsibility that we cannot afford to ignore. Thank you very much.
Thank you very much. That's really helpful framing for all the things that we've been discussing. Really pull all the way out and think about the additional concerns that are being raised by all the aspects of climate change and the challenge that that gives to all countries. So now we're going to move, and we'll hear a more methodological talk as prepared by Richard Pito and presented by Sarah.
Thanks, everybody. And sorry, I'm not Richard Pito. I think he got many references this morning, so I was feeling worse and worse about the fact that it wasn't going to be him. But anyway, I'll do my best. So this is Richard's talk on the magic of randomization and of Mendelian randomization versus the myth of real-world evidence. So I think you can already see where this talk is going. And it's really about the frequent need for reliable assessment of just moderate effects on mortality from secondary prevention treatments. So a version of the slide I gave this morning, but worldwide, about 3/4 of the premature deaths at ages 30 to 69 are from vascular diseases or cancer. And targets for both primary and secondary prevention should be smoking cessation, blood pressure, blood lipids, and adiposity. So how do we achieve these, or what's the evidence for these? So smoking cessation shortly after a myocardial infarction substantially reduces 5-year mortality. Observationally, 10 units lower BMI yields about 1/3 lower vascular risk, and that's throughout the usual range of systolic blood pressure. And the clinical trials have pretty much backed that up, that within about 5 years of treatment, you achieve most of that epidemiologically expected reduction in risk. And data from the cholesterol treatment trial is that a good generic statin regime reduces LDL cholesterol by about 1.5 to 2 millimoles per litre, and that safely reduces occlusive vascular risk by about 30 to 40%. So for those with disease, but still with a good quality of life, that if we can achieve those, it's really important that we ensure affordable availability and widespread use of the generic statins, blood pressure lowering drugs, aspirin, etc. And that kind of comes back a bit to the polypill talk that we had earlier this morning, and talk of whether people actually take their medicine, so that about widespread use. And so it would be really interesting to hear tomorrow about how people achieve that. And the advantages of this approach is that it doesn't require any screening program to find who to treat. It doesn't require medicalisation of apparently well individuals, but you prevent a lot of lives by, these are the people who are at highest risk of having another event. So if you can get to them while they've still got good quality of life, then it really is a cheap and effective and efficient way to prevent secondary events. And therefore it's practical in both high and in middle income populations, and could reduce NCD mortality within about a decade, whereas substantial life changes are really difficult. They are just difficult to achieve, and they're difficult to sustain, and so would take longer to achieve the same result. So the two chief needs in secondary prevention: ensure that those known cost-effective treatments actually get given, and if they're given, that they're actually taken, so have good compliance. And again, as I've just said, I think tomorrow we'll hear about how to get systems to do this, because it's just as challenging, and I don't know, maybe I think we might find out tomorrow, more challenging than evaluating the new treatments in the first place. And then determine by randomized trials or otherwise whether particular secondary prevention methods yield those worthwhile benefits. And I think the important thing is that where there's substantial uncertainty about the treatment efficacy, the true effect may well be only moderate. We're usually over-optimistic about these treatment effects, or even negligibly small. And if so, randomized evidence is needed to assess these effects reliably. So how do we do that? Large randomized trials or meta-analysis of trials can assess treatments reliably, and the large biobanks can, by Mendelian randomization, assess genetic factors reliably, which may help us to discover new and effective treatments. But the biobanks themselves can't assess the moderate treatment effects reliably. So we might assess the genetic factors, we might help discover new and effective treatments, but we still need those randomized trials to test them out. And I think importantly, nor can analyses of databases of non-randomized treatment records, which misleadingly get called real-world evidence, they can't evaluate these prevention methods reliably. And I'll come on to that in a minute. But I think it's really tempting to go for this real-world evidence because you just get vast amounts of data, but the huge problems around the biases that those incur are huge. So why randomise? Well, because why don't we just analyse those routine medical records, get the real-world evidence of what seems to work? And it's because of the frequent need for reliable demonstration. I keep coming up with this word, or refutation, of the moderate effects on mortality. And if we're going to assess moderate effects reliably, then we need negligible biases and small random errors. So my instructions on this are to go slowly and carefully through this slide. So forgive me if I go slowly. So the requirements of these to achieve these negligible biases and small random errors, you need proper randomization. The non-randomized methods may well suffer from the moderate biases. Analysis by allocated treatment include all randomized patients in the analysis at the end. In other words, the intention to treat analysis. The participants who drop out are often systematically different from the participants who do not drop out. So the per-protocol analysis is going to give you a biased result. And the chief emphasis of that trial should be on the primary endpoint, on the overall effect on the primary endpoint. So no unduly data-dependent emphasis on particular subgroups of either patients or of the disease outcomes, and a systematic, and also if there are several trials, then a systematic meta-analysis of all the randomized trials, because this will need the largest possible total numbers, so give you the least random error, but again with no unduly data-dependent emphasis on particular studies. And avoiding the small random errors, that large numbers in any new trials, and they need to be really large trials, which should be streamlined. And this is where you do, as Richard's example from the recovery trial, using the real world evidence to get your outcomes, but not to get your treatment effects or your treatment exposures. And then, as I've just said, the systematic meta-analysis of the trials to get the largest possible numbers. So example from breast cancer, where large-scale randomized evidence has identified several moderate effects that just could not have been reliably demonstrated by non-randomized methods. And this is the graph of breast cancer mortality at ages 35 to 69, 1950 to 2020 in the UK and the US, and see this dramatic improvement in breast cancer mortality from from about 1990 to 2020, so over the last 30 years. And that's by combining several moderate treatment effects, and that further moderate effects are still worthwhile and achievable. So the Early Breast Cancer Trialist Collaborative Group, which with the Secretariat in Oxford, I think was established about 40 years ago to assess moderate survival differences. And 40 years ago, the breast cancer trialists got together, agreed to regularly share all their data. And by doing so, they found moderate 10-year gains from radiotherapy to the conserved breast after breast conserving surgery. Better chemotherapy, first of all, standard chemotherapy, chemo versus no chemo, then intensive, more intensive versus less intensive. And then more recently, the better endocrine therapy. So first of all, it was tamoxifen versus not, then 10 versus 5 years of more versus less tamoxifen, then the aromatase inhibitor versus tamoxifen, then 10 versus 5 years of AI, all of them cumulatively giving sort of moderate treatment effects, all of which have added up to that huge decrease in breast cancer mortality over the last 30 years. So to conclude, I like this, I don't think I would ever write this. Getting large-scale randomized evidence is horribly difficult. And I think Richard would show that. He showed quite nicely. He talked about how difficult it was, but I think, Richard, you give a nice sort of 2 slides of how this was done and make it all look so easy. And I know from being in a department with you for several years that it's not easy at all. It is horribly difficult. And as Richard pointed out, the over-regulation of randomized trials has and continues to make it even more horribly difficult. But I think this is really important, that the efforts to replace or even to complement the randomized controlled trials by non-randomized real-world evidence can yield moderately biased results, because the disease severity can just differ subtly between people and affect the treatment, subtly affect the treatment choices. And I think COVID, again, was a great example. You heard it this morning, but where the randomized controlled trials yielded reliable positive and negative findings, where the real world evidence yielded seriously false positive results on remdesivir, hydroxychloroquine, and convalescent plasma. So, thank you.
Thank you very much indeed. That was really very helpful, and it was very kind of you to agree to give 2 talks in the same afternoon. So now we have time for discussion of both talks. So do we have any questions or contributions from the floor?
I mean, I as someone who runs cohorts and tries to make those cohorts as representative as possible to get observational data that relates to representation in the population, how important is it for randomized trials to consider a reference population at the same time? So it's a slightly leading question, but I think it's worth airing.
I'm not quite sure. Do you understand the question? In which case you can answer it.
Tag team. So I'll check I understand the question. Do trial populations need to be representative? I don't think they do. And I don't think that's, I think there's a bit of confusion that's partly come about from the absolutely correct desire for trial populations to be diverse and to be inclusive. That I think is absolutely fundamental. Everybody should have the right, if you like, or the ability to get into a trial if there's a suitable one running. But I think some people have assumed that I think that is sufficient justification. I think some people have assumed the justification is that you then try and create a representative population. My problem with that is that I don't know what it actually represents. I said that in recovery we did roughly represent the UK population, but that was the UK population at the time in that pandemic. And if I did my trials in kidney disease, if I tried to represent the UK population of people with kidney disease, it wouldn't represent the US population with kidney disease, and it wouldn't represent the UK population of kidney disease in 5 or 10 years' time. So I don't think it's very helpful. And the reason that people often think you need representativeness is then so that you can generalize the results. And I absolutely don't think that's how science works. There's probably much more learned people here who could talk to the fact that in most fields of science, you do not seek representative data to generate generalizable results. It's just not that sort of mixing up. I think for cohorts and when you're surveying populations, representativeness is important. Actually, I think that's a slight exception to most other science where it's not. And you can generalize from the results, from randomized trial results, the relative effects generalize quite well. And we know that empirically in situations where we've had 150 trials of blood pressure lowering. It doesn't really matter what the population is, reducing your blood pressure by a certain amount causes approximately the same relative risk reduction. So slightly long-winded answer, but sorry.
I think I'd just add to that though about the cohorts. I don't know that they need to be representative. Obviously they do if you're wanting to look at prevalence of disease, but if you're looking for associations, I think it's the same as in the trials that you want diversity to see if things differ, but you don't need it to be representative.
Thanks. Just, I guess, question / comment for Prof. Pranasham. I mean, you showed quite nicely how, as the world has become wealthier, I guess, or income for many countries has gone up, and disease and things have come down, and then inequality has gone up. I mean, how much of that do you think is solvable by healthcare and us and science? Or is it all really just the way the world works in terms of the economy, in terms of debt, in terms of capitalist approaches, etc.? So if so, I mean, is this something that any of us can actually do anything about? Or is this more for government to kind of, or not even government, the world, I guess, to figure out how to solve that?
So that was just the socialist in me ranting about how unfair the world is. So I wouldn't say that anyone in this room would have the power to be able to influence that. But to me, the important thing is to be able to recognize that and to try and ensure that whatever intervention we might think about as a potential solution to problems takes that into cognizance when we are offering a solution. The problem that's happening, and it's as common in low middle income countries as it is in high income countries, is the fact that, especially with therapeutics, we have these new extremely expensive interventions, whether it be robotic surgery or proton therapy or the new immunotherapy molecules, which come at an extremely high cost, but with, as I showed in the US FDA approvals, with very marginal benefit. And patients are somehow convinced that that's the way to go as far as getting cutting-edge treatment is concerned. And they actually resent the fact that governments don't support those treatments, especially in countries which don't have a formal health technology assessment like you folks have with NICE. India has health technology assessment at an infancy. We don't have the ability to look at every single intervention through the lens of health economics. So it does create that perceived exaggeration of that inequity as far as a patient is concerned. There's a rich patient who pays out of pocket and gets the best care, whereas someone funded through the public system gets so-called inferior care, which is actually not true, because all that the rich patient is getting is a couple of months of additional survival.
Similar problems in the UK. I mean, although medicines are kind of rationalized by NICE in that sense, there is a growing pressure that this is not affordable anymore, and that rationing process is going to get even worse, in which case some people will get something, some people won't. I guess it's a kind of more philosophical question, really, is that the way things have worked in the world thus far has generated that wealth, which has generated improvements in public health and economic standing for everyone, and it looks like maybe a byproduct of that is a forever trend towards worsening equity. So yeah, I don't know if AI is going to solve that or whether climate change will sort it all out for us anyway, but I don't know. It's all going to make it.
No, information technology and biotechnology will make it. They will invent a chip that you will put on your skin and it will tell you about every metabolic change. And probably we will not be healthy, and none of us will be healthy at some point of time. We'll all have some disease that the chip will tell.
So I don't think I'm as pessimistic as that. Certainly, AI did exacerbate some, not just AI, it was just regular tech, during the pandemic, what we noticed was that school children who suddenly had to shift to a virtual platform were far more disadvantaged amongst the poor as compared to the rich, because poor families had just one smartphone or one device to work, or none. And suddenly you found that the ability of the child to get an education by just going physically to a school was hampered by the fact that they had to rely on technology. But having said that, I think there's plenty of opportunities to use AI in an ethical and morally acceptable way. Diagnostics is something which I'm convinced will narrow the gap in access to high quality pathology and radiology if we use AI well.
I mean, I don't really need a mic. I like what you said about the artificial dichotomy between NCDs and infection. But I have two questions. Does this really impact the budgetary allocations by the government? I'm not sure. All I know is. Oh, I'm sorry. All I know is the budget for mental health is very poor. That's all I know. But between the NCDs and the infectious disease, do you think the same kind of thought runs through with government spending so much money or allocating in the health budget? My second question is, I think the insurance lobby in India is as bad or as powerful as a tobacco lobby. So if the insurance premium can be reduced, do you think that will help equity to a certain extent?
So I think it will certainly help, and a more rational, more transparent way of having your insurance premiums decided would go a long way. But looking at it from the, I'm all for reducing insurance premium. But when you look at it from the opposite side, and I learned this much to my surprise when I was discussing this with the National Health Authority, that the proportion of fraudulent claims for insurance in India is close to 40%. It's not a negligible figure, which necessitates that often for very legitimate claims, insurance companies reject it, and vice versa. So I think that part of it is because we haven't really found a reliable way of avoiding fraud. But now with the growing use of electronic medical records, the fact that digital health data can be shared across organizations, this will hopefully come down. Your first question was on the budget. So I don't think it truly should affect health budgets, but it's just that when we speak to governmental organizations, we are fragmented in our approach. The cancer specialist wants X amount of money to be allocated for cancer, and someone else wants it for liver disease, and someone else wants it for infectious disease. And somewhere I think we end up creating these siloed budgets and expenditure buckets within the government, which don't talk to each other, whereas a more unified approach would actually help in reducing costs both for the government as well as for the individual patient.
Thanks. Just a comment on some of the inequities piece. It's definitely true that most public health interventions can actually widen inequalities because those who are more primed to take up messages are more likely to hear them. That's for sure. But it's actually it's not. I can see how you would say that it's completely baked into basically capitalism, but it's also true that the greater the inequality, the worse outcomes are for the whole. So the wider the bell curve, the bell curve itself, it shifts to the right. I mean, unless you're talking about extreme wealth, but generally for the population, we don't want our hospitals just to be filled with people who are there because it's cold or hungry, right? So as a policy priority, reducing inequality should always be central, not just because it's sort of a nice thing to do, but actually because the health of the whole country, the whole system should improve in theory.
I think just to put a bit of context, now I'm not disagreeing with anything you've said. I think this was more a discussion I'd actually had with a colleague who's an economist, who controversially said that economists are more important than doctors for the wider good of society. And it's controversial. You can see it could get us all quite excited, but there's probably an element of truth in there about how the wealth and the wealth distribution of nations impacts pretty much everything that we're talking about. And then the related comment from that is, well, how much of that can we influence? Is it more about policy, about lobbying, about financially reducing inequalities, as opposed to trying for us to reduce health inequalities in kind of substantial ways, and that the health inequalities will dissipate as the wealth inequalities dissipate.
So, what we are discussing today for reducing inequity may not hold water 10 years from today. See, with AI coming up, there's a lot of concern that a lot of jobs will be unnecessary, which means, see, we can talk of inequity because it's a strong body of people who work and they demand better care. What happens if that large workforce becomes irrelevant? And then what will happen?
All right. So we can't be accused of not asking and discussing the big questions now. But it's really been very helpful to have a sort of wide-ranging discussion from themes that came up about the importance of simplicity, about identifying what's really important and sticking to that and not making it overly complicated, to keeping your eye on these other questions that are sort of societal scale, but thinking about potential unintended consequences. So we are back here tomorrow. Do you want to say anything about the transport here? Because it seems like we're going on in one bus rather than in two as originally advertised.
Well, there was two this morning, but they were later than I was told. So
Okay.
I think it's the original plan for the morning. I'll let you know. And even now, the first bus is at 5:30.
Great. Thank you all very much. Thanks again to all the speakers.